Good evening. Welcome you all to this session of this month's TNISG meeting. We will start off with this. We have two sessions on the postgraduate session as well as the CME part which follows. So welcome you all to this evening, and I request President Dr. Prem Kumar to welcome and begin the CME, please.
Senior colleagues, PGs and friends. You all know our society has been a very active and vibrant society, and we have been conducting meetings on a regular basis, and we have been improving upon ourselves. And then initially in those days it used to be only topic discussion. Now the session on PGs and the PG presentation and review of Indian literature, things are really good. And then unfortunately we have seen only PGs who are presenting or coming, and most of them are not coming. And then it is only for them. Maybe you can tell your friends that this meeting is only for you, for postgraduates to upgrade, and then it definitely will benefit a lot. So these few words, I would like to welcome all the speakers, chairpersons, and everyone for this meeting. And without wasting much time, I hand over the mic to the chairpersons to take over and conduct the proceedings.
So it's very, we have very interesting cases today, as in every other meeting. So we'll start the meeting by a presentation by Dr. Farunullah on cholestatic jaundice in the young, unraveled.
Good evening, everyone. Today we'll be discussing about an interesting case of cholestasis in young. A patient of age 23 who presented with complaints of yellowish discoloration of eyes since 1 month associated with itching and pale color stools. Patient has no history of fever, alcohol intake or over-the-counter of drug intake or CAM intake, no history of high-risk behavior, no blood transfusions history. Patient had no history of anorexia or weight loss. He had no history of neonatal jaundice. Coming to past history, patient had similar complaints in the past. He had 2 episodes of jaundice, one at the age of 20 and 21, associated itching and pale colored stools. Each episode lasted for 2 months, resolved on its own. No similar complaints in the family. Coming to personal history, he take mixed diet, appetite was decreased, sleep was normal, bowel and bladder habits were regular. Coming to physical examination, he was hemodynamically stable, and general examination, icterus was found, no signs of liver cell failure to be found. Coming to systemic examination, all systems normal, per abdomen soft, non-tender, no organomegaly, bowel sounds were present. Depending upon the history and general examination, we made a provisional diagnosis of recurrent cholestasis. However, we need to exclude known causes of jaundice like hepatitis B, C, PBC and PSC, autoimmune hepatitis and inherited disorders of cholestasis. So depending upon that, we did a few investigations in which hemogram showed HB of 14, total counts of 6,200, platelet count of 2.9 lakhs, INR of 1.1. Viral markers B, C and anti-HBC total are non-reactive. Coming to LFT, total bilirubin of 17, of direct fraction 9, SGOT was 43, SGPT was 40, alkaline phosphatase was elevated 200 with normal GGT, total protein of 7, albumin of 4 and a globulin of 3. To rule out the causes of jaundice, we did a few workup, like KF ring was negative, serum ceruloplasmin was normal. To rule out autoimmune hepatitis, we did ASMA, ANN, anti-LCAM, which were negative. To rule out Wilson's, we did the serum copper levels, which were normal. And AMA was also done, which was negative. As a part of imaging, we did ultrasound abdomen, which showed no abnormality. So depending upon that, we made a working diagnosis of cholestatic jaundice, probably familial, like BRIC. So as everything was known causes were negative, so we planned for liver biopsy. In this liver biopsy, this is a hematoxylin eosin stain at 400 magnification, showed preserved hepatic parenchyma with intrahepatic cholestasis. This brownish golden color like thing suggestive of cholestasis, so supporting the cholestatic pattern of jaundice. So all the investigations on liver biopsy suggestive of cholestasis. Then we planned for whole genome exome sequencing, which came positive for ATP8B1, which showed heterozygosity, suggestive of pathogenic variant of BRIC type 1. So followed by patient was treated with ursodeoxycholic acid and cholestyramine, for which patient improved significantly, and we gave psychological support and explained about the disease progression and everything to the patient. This is the LFT trend. On presentation, total bilirubin of 17 with elevated ALP with normal GGT. It went up to bilirubin went up to maximum of 34. Then later on during the course, bilirubin became normal on day 45, becoming up to 1.2, with normalizing ALP of 120. So we made a final diagnosis of benign recurrent intrahepatic cholestasis type 1. Benign recurrent intrahepatic cholestasis is an autosomal recessive disorder which was first diagnosed by Summerskill and Walsh in 1959 as a cause of jaundice. Incidence of BRIC is 1 in 50,000 to 1 lakh people, whereas prevalence is not clearly known. Usually they present at age less than 20 years of age. Coming to genetic aspects, BRIC, PFIC and intrahepatic cholestasis, they share a similar genes involvement associated with intrahepatic cholestasis. Two types of BRIC has been diagnosed. One is type 1, where ATP8B1 is involved. In type 2, ABCB11. Here I'll briefly explain about the pathogenesis of BRIC. Once the bile acids are formed, when bile acids are conjugated to taurine and choline and bile acids are formed, they will be exported into the canaliculi. In the canaliculi, three membrane proteins are there. One is F1C1, bile salt exporter protein, and MDR3. F1C1 is coded by ATP8B1. Bile salt exporter protein is coded by ABCB11. MDR3 is coded by ABCB4. F1C1 is implicated in BRIC1, PFIC1 and ICP, whereas BACP is implicated in PFIC2, BRIC2 and ICP, and MDR3 is in PFIC3 and ICP. Basically, F1C1 and MDR3 helps in maintaining the lipid asymmetry around the canalicular membrane. Like phosphatidylcholine inward outward movement they will maintain. This along the BACP helps in exporting the bile salts into the canaliculi. If F1C1 is affected, so there will be less input of phosphatidylcholine inward movement. If MDR3 is affected, there will be defect in exporting the phosphatidylcholine into the canaliculi. Phosphatidylcholine main function is to protecting the canaliculi from the bile salts. There is a basic difference between the BRIC and PFIC. Generally, PFIC presentation occurs mainly in the very early young age, as such as 1 to 3 months only, and BRIC generally presents in adolescence, early adolescence. PFIC patients may progress to fibrosis and cirrhosis, whereas BRIC patients doesn't progress to cirrhosis. Common triggering factors of BRIC are like hormonal changes like OCP, pregnancy, even hyperthyroidism is implicated. Infections most commonly like GNV and some viral infections like COVID is also implicated. Coming to clinical presentation, these patients present with pruritus, anorexia, nausea, vomiting and weight loss. BRIC1 may be associated with pancreatitis. Cholelithiasis is seen in BRIC2. First attack usually occurs in childhood or early adolescence, can present in infancy or adulthood also. Each attack may last from weeks to months or even several years. During symptom-free interval, patients may experience good health, whereas liver biopsy abnormalities are observed only during the attacks with intrahepatic cholestasis resolving during the asymptomatic intervals. A distinctive feature is like absence of progression to cirrhosis, which differentiates it from PFIC. A diagnostic criteria has been established by Leuketic and Schiffman, which has 6 components. First is like at least two attacks of jaundice separated by symptom-free interval, lasting several months to years. Second is laboratory values consistent with intrahepatic cholestasis. Third, severe pruritic secondary to cholestasis and with liver histology demonstrating centrilobular cholestasis. Other will be normal intra and extrahepatic bilates by imaging, and absence of factors known to be associated with other factors known to be associated with cholestasis should be absent. Diagnosis is by genetic mutations, which supports and confirms the diagnosis. Management mainly will be symptomatic and supportive. Symptomatic mainly will give drugs like in BRIC will generally treat with the UDCA, which helps in changing the composition of bile to hydrophobic and increases the bile flow, and it has immunomodulatory effects also. The second most commonly used is cholestyramine. Cholestyramine is a non-absorbable polystyrene which binds with bile acids and interrupts the EHC. The antibiotics another antibiotic which used in pruritus management is rifampicin. Rifampicin is a pregnan X receptor which upregulates the bile salt excretion on acting on BSEP. Opioid antagonist like naltrexone is also used, which acts on mu opioid receptors by decreasing the pruritus. Newer drugs like fibrates, bezafibrate and fenofibrate are used, which decreases the bile acid synthesis and increases the bile flow. New group of drugs like ileal bile acid transport inhibitors like maralixibat and odevixibat, they usually bind with the bile salts and inhibit the bile acid reabsorption in the terminal ileum. These are the newer drugs which can be used if patient is not responding to conventional treatment like UTC and cholestyramine. And at last, the patient should be advised for genetic counseling, like patient full family history has to be assessed, and the education about the BRIC should be explained to the patient, and inheritance patterns like if 25% of offspring having a chance of getting affected and 50% chance of having carrier risk should be explained, and the patient should be explained about the reproductive options like IVF or adoption methods or to eliminate genetic risk. And at last, the patient should be addressed about the anxiety and coping mechanisms regarding the disease.
Thank you, doctor. Any comments, madam?
Just to highlight that low GTP is the clue for all these cases of PFIC, BRIC and ICP. Otherwise, you will not get. Bile salt transport disorders is the only one, except PFIC3, you will get low GTP, and in bile acid. That clue is there. Yes. So that low GTP. And the other one is, we want to tell everyone that though we think it is BRIC, it may not be benign. I think we have referred one patient to Stanley. We have to do plasmapheresis for that child. It can go very high, requiring that amount, and I feel the whole thing is a spectrum between BRIC and PFIC. After all, if it is the same gene, and this is heterozygous and that homozygous, it needs just one more hit, either a drug, Ayurvedic drug, or some toxic, it will go bad. So I think we have to tell them he's on the brink. Don't just say BRIC, benign. That benign gives us a thing saying, oh, everything will be all right. In that series which we have published, 2 got married, they have children, but during pregnancy they did have a very bad cause. Because it is ICP. No, most of these are missense mutations. So rifampicin works better for them. So I think we should remember that, plasmapheresis may be required, and even there is a report of a transplant. Then intractable itching. See, this one has come little late. 16 years, and then adolescent, that boy felt so bad, he could not manage that. He was going in for depression because of that itching. So everything, it's not, though it looks benign, no, it's not always benign. I think a few of them do very badly, and it all depends on the type of mutation. It's a big spectrum, the whole thing is a big spectrum. But it may not be as progressive as BRIC, it may start later, but it can progress. I think others also will have the same thing. Rifampicin is a good drug. I think that we should remember. Though we classify it as a hepatotoxic, it can be still used in this because of the different mechanisms.
Madam, do we always need to do a liver biopsy for this patient?
It's not necessary, but if you, especially in research centers and academic institutes, it's always good to do. See, the only thing is when you have direct bilirubin high, but GTP, normally you also think of
Is GGT, ma'am? Gamma
glutamyl transferase. Yeah. So that is that's the clue there. When you expect, when the alkaline phosphatase is high, the enzyme, this one also should increase. So when that doesn't increase, then you wonder what it is.
Anybody, any other persons?
Why is it recurrent? Why it's recurrent?
Sir, in between the patient,
Why does it gets well on its own?
Why it get
Recurrence
better?
usually everywhere all over the world. Even I think when that person came from UK, he is the one who's done a lot of this work. A respiratory infection. Some cold, some respiratory infection they would have got and their trigger will start. Or it will be some drug which they might have taken an amoxicillin or something like that which gets triggered. This boy who became very sick, as usual in our place, போயும் ஒரு ஜாண்டிஸ்க்கு அலோபதிக்கு போனியா அந்த டாக்டர் போனா I'll give you medicine அவ்வளவுதான் முடிஞ்சே போச்சு. The whole thing got spoiled. Triggering is a respiratory infection in the world. Yeah.
Keeping them under a treatment is very difficult. Sometimes some of the cancer patients, advanced cancer, secondaries. Sir, cancer is okay, sir, but jaundice, what do we do? There is a question they ask, and preventing them from going and taking some other CAM medications and mistakes is very
Have they done
difficult.
any transplant for this? Everyone think someone is good. In Rayla Institute they've done. Because I think they just put it as a bile salt transport defect. And they are progressing. Though we call it benign, we hope it will be benign.
Is it done for a liver failure or a itching?
See, the cholestatic disorders itself, the indication for transplant is intractable. One of them is intractable itching. Quality of life. Poor quality of life. Always it's not failure, your indication for transplant. Poor quality of life and intractable itching which is not being thing. You tried plasmapheresis, not improving. Then you have to take them. Before they go for liver failure, we have to take them. This boy went in for liver failure by the time.
What is the incidence of relapse in the transplanted liver?
They don't have because they think they get the thing. They don't. They do very well. This is unlike PFIC1 where you can't do a transplant because it's a multisystemic disease. The pancreas will go, they will not grow, they are that bonsai children. PFIC2 you can transplant, you must transplant early because they go in for liver malignancy, but they get autoimmune rejections after transplant, but you have to be careful. 3 is very good for transplant. So I think each one they've got. Now we've got 12 PFICs. PFIC is increasing, so you knew 3, we knew 6, now there are 12.
My second case, correct?
Now you can put
I
it.
presented one case again.
So we
Second case.
just
But mostly it is recurrence happens because of a trigger, like madam said. Either some CAMS intake or some viral infection causes the trigger. Again it goes on and then for 2-3 months then
My understanding was like it's a heterozygous. So you have functioning pumps which is still active. Once the threshold is above, then you have got it. When you assist by medications to bring down the bile acids and bilirubin, then it goes back to normal. Again, there is if it goes above the threshold, then probably they are going back. It depends on how much
even
they can
for
tolerate.
them, ursodeoxycholic acid does not work,
Yes.
even in PFIC. That it all depends on what type of mutation. Missense mutations, only some group works. That's why even in PFICs and all, they don't work. 35% only works. It's only a small group. So everything is again going back to your mutation. Is it missense, heterozygous, or what is that? What have they said in that? That you have to see and then. Anyway, now only we are all learning. So as we learn, we will know more. Steroids is that whitewash effect, I think, given by Sheila Sherlock, not for this. Here, only 3 things work. Probably it is ursodeoxycholic. If it works, rifampicin and cholestyramine. We use cholestyramine for some of those in that series. And then it is biliary diversions we were doing. We are doing internal biliary diversion. Many people prefer the external biliary diversion. So all that you have to do, like he said, that ileum, that you cut that and then you divert it inside. So you don't allow it to enter. So you allow it to enter the ascending colon.
Once our pediatric gastro has asked us to put a nasobiliary drainage tube.
So that's all.
Just to
Tide over the crisis.
Yeah.
Otherwise, for the PFICs intractable itching, we've had very good results, especially for PFIC1, we just did an internal biliary diversion. All that you take, you avoid that ileal to hepatoileal circulation and you connect it to the ascending colon. So you cut it off. And so then this goes in and you don't get that recirculation.
If we had done genetic testing first, we could have avoided liver biopsy?
Liver biopsy is for our own learning. We should know what is happening.
Okay.
Suddenly you will get something new. I think the liver biopsy, we should be able to do it required.
Invasive,
You learn more. You won't know what is happening inside.
Any role of hyper restriction, madam, because all the things come with the phosphatidylcholine choline, you know. Any restriction, any studies on that?
No dietitian, no dietitian. Even for those children, we give them all the ADE, K vitamin things, supportive. We give them 120% calories because you treat them like a cholestatic disorder if they are homozygous. If they are homozygous, then you have to, because they will have nutrition will be impaired. The cholestasis, they don't absorb properly, and especially type 1 and all that, they won't grow. So you have to supplement and give them nearly 100 to double the calories required with fat soluble vitamins. Not for this. Here they grow very well. That's what I said. They get married, they have children. It's only we should not do anything in between.
One young boy, I think Dr. KRB's patient, I was working along with him, he used to present with recurrent pancreatitis. And during the episode of pancreatitis, his bilirubin will go up to 30, 40. So I think BRIC1 or some type is associated with pancreatitis, and they used to have significant coagulopathy. He also developed a cholelithiasis subsequently. He needed a cholecystectomy, then he had a bleed. So many problems happened. Are they associated with any coagulation defects also? Or
BRIC, sir. BRIC, they are not mentioned. Sir. Coagulation defects are unmentioned. Sir. In PFIC, they might have coagulation defects.
Okay.
Homozygous pain, all things they have, because now they are very difficult to manage. Some of them we lose them even in the neonatal period. Some of them, the type 4 TJP2, tight junction protein 2 defect, is also a bile salt transporter. It have the same features, but they go in for things so fast. Many of them are prone for liver malignancy, high malignancy. Had one child sent for transplant. I just didn't do CT again before that. Explant liver showed the malignancy, 2.5-year-old child. So the ability to go in for that type of potential is there for them. So it's not mild, except PFIC1 who can grow, but they will not grow thing, but you can. That's why it's progressive, means it's very progressive.
Is there a role for vaccination, ma'am? Because respiratory infection is a frequent trigger for this episode.
Yes. All children should be vaccinated. These children especially should be vaccinated. They get their flu shots every month. They get it every year.
We'll move on to the next case. Dr. R. Arvind from Gleneagles Health City, Chennai. Case of slip and cut, ESD for duodenal NET.
Good evening, everyone. So I'm going to present a case of duodenal NET that we manage in our hospital. Okay. So the patient was a 51-year-old female. She had a history of serous tubal intraepithelial carcinoma, for which she has undergone total abdominal hysterectomy and bilateral salpingo-oophorectomy in 2018. So she was from then she was asymptomatic, and she was undergoing PET CT regularly. And one PET CT that she did this year picked up a hypermetabolic nodular thickening with arterial enhancement on the lateral wall of duodenum. The size of the lesion was around 1.1 centimeter, and the chromogranule levels were also high. It was 240 nanogram per liter, and she went for a gallium dotatate scan, which picked up an isolated lesion in the D1 with no nodal uptake or any uptake in the liver. So an endoscopy revealed an isolated subepithelial lesion of size approximately 1 centimeter in D1. EUS revealed a hypoechoic lesion in the submucosa with intact muscularis propria. So the treatment options are available are a modified EMR, ESD, EFTR, or a surgery. Since the patient has a subepithelial lesion in endoscopy with high chromogranule levels
and the hypermetabolic uptake in PET CT. We had a diagnosis of neuroendocrine tumor in our mind, and since the size of the tumor is not very big, it was just above 1 centimeter, so we suggested the option of EMR and ESD for the patient, and the patient opted to go for modified EMR, and this was also discussed in a multi-departmental meet, and we went ahead with the modified band EMR. So this is the lesion. So we plotted the margins of the lesion prior to raising the submucosal cushion. The cushion was raised, and using a band ligator, we applied the band. But unfortunately, there were 2 bands that got deployed. And these bands didn't last long. It was actually during the procedure, we ourselves saw the band slipping out during the procedure. So since the lesion and the area around the lesion was highly inflamed during that procedure, the procedure was abandoned and we didn't proceed further. We explained this to the patient and their attenders, and we suggested them to go for ESD on a later date. So the following month we suggested them to go for a ESD. So she was posted. The margins of the lesion was plotted using 1.5 centimeter dual knife with coagulation current. Submucosal cushion was raised, followed by circumferential incision around the lesion. After completing the circumferential incision around the lesion, again submucosal cushion was raised, but you could see that the cushion was not able to be raised as we were able to do it in a POEM procedure, because it's duodenum. It has a very thin wall, and in order to provide effective tissue traction, handheld tissue traction was applied using hemoclip tied to a silk thread. So applying tissue traction manually, we were able to dissect further with ease. So this dissection was done very carefully, and we could see some muscle fiber coming in our way, and this was the complete dissection of the tissue. Luckily, we had no gross bleeding during the procedure, and you could see the tissue being removed on toto. So this is the mucosal defect. So once we finished completing our dissection, we placed a loop over the lesion, and the loop was attached to the margins of the lesion using hemoclips. So along the margins of the lesion, the loop was attached using hemoclips. So after completing the applications of the clip, the noose of the loop was closed using the hook. So once the noose is tightened, it works as a purse string suture. Similar to a purse string suture, the margins of the mucosal defect gets approximated. So the defect was closed using loop and clip technique. So this was the tissue that was removed. And 1 month later, if you see, the area was completely healed. And just to highlight the procedure, this was the lesion. The lesion was plotted using dual knife and coagulation current. Submucosal cushion was raised. Curvilinear incision was done. Handheld tissue traction was given. Dissection was proceeded. And this was a defect. And this is the tissue. And the histopathological examination revealed clusters of islet cells and minimal to no, absolutely no ATPR. And the K67 index was less than 3 in this patient. And immunohistochemistry staining was positive for synaptophysin, and there was a strong cytoplasmic positivity. So duodenal NETs, it accounts up to 5% of all neuroendocrine tumors. The mean age of presentation is during the 6th decade. It has a slightly more predilection in males, for males to develop a neuroendocrine tumor than female. And duodenal NETs, they arise from deep mucosal tissue and they invade the submucosa and they proceed down. And most of them are solitary and they are diagnosed incidentally. So some of the important figures that we should keep in mind are more than 90% of the duodenal NETs occur in D1 and D2. Most of them are solitary, but if there are multiple NETs that you are seeing in the duodenum, then you should think of men. Only 9 to 13% of duodenal NETs are multiple, but when you find them, you should keep men syndrome in mind and neurofibromatosis type 1. So men 1 accounts up to 6% of all duodenal NET, and the mean size of duodenal NET is approximately between 1.2 and 1.5 centimeter. And almost majority of them are less than 2 centimeters. And 63% of patients with duodenal NET, they have they remain in the mucosa and submucosa, and muscularis propria is almost always intact. And they have a 60% chance of metastasizing to lymph nodes, and which is directly proportional to the size of the lesion and the degree of mitosis that they have in histopathology. So this is the classification of duodenal NET. They are classified as non-functioning, functioning, duodenal paragangliomas, and poorly differentiated neuroendocrine carcinomas. Most of them are non-functional, and among the functional, gastroma is the most common, followed by somatostatinoma and carcinoids. So, but if you find if you find a ampullary neuroendocrine tumor, then we should think of duodenal paraganglioma and somatostatinoma because they tend to occur from the ampulla. And ampullary neuroendocrine tumors amounts up to 25% of them. WHO classification of neuroendocrine tumors includes histological classification only, which is graded as grade 1, 2, and 3 based on the mitotic index and K67. When the K67 index is less than 3, it is grade 1. If it's between 3 to 20, it's grade 2, and it's more than 20, it is grade 3. And higher the mitotic index and higher the K67 index, the more chances that they get metastasized. So the TNM staging, this is likely to be upgraded, expected to be upgraded in some few years because it was published in December 2021, which says that T1 lesion that is less than 1 centimeter is confining to submucosa is considered to be T1, but all studies show that patients with size more than 2 centimeter and deep and more than 2 centimeter and increasing depth of the lesion is the most important prognostic factor than size being less than 1. So the cutoff of 1 is likely to be expected to be changed in the near future. So the immunohistochemistry markers that are important to diagnose duodenal NET are AE1, AE3, which denotes that they are arising from the epithelial region.
Arvind, and can go to the conclusion slide now.
Okay, sir.
It's time.
So these are the challenges that we face. So endoscopic challenges that we face during the procedure are the anatomy. So it is due to sometimes we find redundant stomach and we could find an acute duodenal angle. We have and there can be poor scope control, And the vertical approach, and sometimes when you will see the duodenum end on to the scope. So when you put the needle in, you can directly go perpendicularly to the lesion, to the duodenal wall, which can cause perforation because the duodenal wall is very thin. And histologically, you find Brenner glands and thin muscularis propria, which are vulnerable, which will lead to full thickness muscle damage during the procedure. And the perforation rate is quite high. It is around 35% while doing a DSD in the duodenum, and the incidence of delayed bleeding is around 22%. So this is the thickness of the duodenal wall. The mean thickness is around 1.6 mm, out of which the most thin layer of the duodenal wall is the muscularis propria. So we'll have to be very careful while doing a duodenal ESD or EFTR. So which is the best endoscopic technique to achieve R0 resection? The best technique is, so if you see the R1 resection positivity rate is high in snare polypectomy, that's up to 90%, and conventional EMR is up to 66%. So R0 resection rate for a modified EMR, for curvilinear incision EMR it is 71%, and band EMR it varies between 61 to 92% depending on the expertise, and ESD is almost 100% and EFTR is 100%. But the risk of perforation is quite high. So the preferred method of endotherapy for a duodenal NET is modified EMR. This has been suggested by various bodies, including the ENETs. So the point that we should have in mind is that higher the size, higher the K6-7 index, more likely the metastasis. Less than 1 centimeter, we can give, it's still a controversy whether we should leave the lesion alone and watch for progression. Between 1 to 2 centimeters, the endoscopic resection is an option, and this is the protocol that we have to follow. Less than 1 centimeter, K6-7 index less than 3, we can observe, but still it's controversial. Only nowadays it is done for patients who are not amenable for both endoscopy and surgical modality of therapy. And if the K6-7 index is more than 3%, then we have to go for somatostatin receptor screening and US screening, followed by surgery or ESD or EMR. If it is between 1 to 2, either ESD or EMR, with if there is a positive lymph node or distant metastasis, then we'll have to go for systemic therapy.
Thank you, doctor. Nice presentation. I mean, very good endoscopic skill. Anybody want to ask questions?
So actually I'll start, sir. See, it's a 1 centimeter lesion. I'm just curious, sir. Why not we put an overscore and cut the above thing, and the cost is going to be the same, and you get a full thickness thing. You put an overscore, it cuts off. In spite of using EFTR is going to cost 1.6. The overscore is going to cost you only 40. Put the overscore, cut the above area. The same thing we get to know.
Overscore is different.
The EFTR device is completely different from overscore clip. If you put a clip, then you can't apply a snare actually. It is an inbuilt device where you suck, then that snare comes inbuilt at the tip of the cup. So it complete resection possible with EFTR, not with the overscore clip and cut.
Presented some 5 cases using overscore. Yeah, I don't know. No, not the
No, they are doing overscore and cutting, but
there was one case where we attempted an EFTRD, but we have applied the clip and the snare fall off like the so we cannot cut it. So the clip is intact. We went ahead and applied a snare around it, and we removed the lesion. That is feasible, but technically challenging, because once the clip is on, you cannot get the margin of the tumor. So it's feasible, but it's technically challenging.
EFTR in upper GI tract is quite challenging. The device is so huge. Putting it into the esophagus is quite challenging. The rectum it is No, I have this is a small lesion. You have done a EUS. There is no muscular propria is normal. You applied 2 banding, so it slipped. Why you didn't try once more another banding? We have been doing banding and cutting for small lesions so many times, You can always try once more.
Actually, the first one you could have seen, actually, it's a prominent lesion. The second lesion, after a month later, it could become it is a very submucosal. It's like very suboptimal.
But one
Visibility.
problem I saw is, I think you injected submucosa and then applied a band. If you hadn't done that, the band will stay there.
No, we have done actually, so we have done almost 4 cases of band EMR. It's much comfortable with injection because after cutting we see what is going on actually, like where you are cutting, where the muscle.
Cutting this submucosal dissection, okay, but
Sir,
for
band EMR, I'm telling you.
banding,
We have cases, we have done 4 band EMR. I mean, there are ways which you can inject or without injection also. People are prescribing different ways actually, like comfortable level. Only thing is, that's why we have a marking to target where to apply the band. And only thing is, after cutting, we'll have enough edges to clip it actually. Like that's what I have feel.
you need not clip it. It is a submucosal lesion, and you have demonstrated very well. The
But it
muscular
can have a
structure is
perforation, sir.
normal.
Delayed bleed and perforation can happen.
It can, but normally it doesn't happen.
But generally we place a clip. In duodenum we don't take a chance, so we always clip it.
Because when you are going below the band to cut it, there is a high risk of perforation. Why not you go? Why did you? I would prefer an ESD directly because anyway you are putting a band, you are going to cut, which is blind, and the current is going to go. You are not going to use endocut QRI.
No, there is always there is a muscular injuries and late perforation bleed. But always you need to close. The easiest method is either you place a band and cut, or you can most of the scenarios you can band and leave it. When you don't want to take any risk, that also is possible actually. After putting a band, you can take a biopsy and come out. Just want to confirm your diagnosis. These are all the options are available. But the only way is actually what we are seeing under vision, you cutting, removing everything. Patient is more worried, already had one malignancy, underwent a surgery, patient was very much afraid. One procedure has failed. We can't afford to have another procedure. That's the idea.
I don't know. I thought it was a very simple case which can be banded and cut.
First of all, sir, like the duodenal NET, we are all removing nowadays. But I don't know what was happening in the earlier years where you would have seen. So recently I had a duodenal NET which we thought, okay, we'll get a multidisciplinary approach. We send it to an oncologist, senior oncologist. He just write it off saying that this is a low-grade tumor. You don't need to worry anything. You can just monitor once in 2 years, and he left it. So we are confused which one to remove, which one not to remove. If it is carcinoid NET, rectal, appendicular or more dangerous, bronchial, the rest of the things are very benign, I believe. So most of them are low grade. If you see that.
So I'll ask him a question. When will it become, when it is what is the KI index?
K index was less than 3, sir.
Less than 3, 2. So what will happen in the future? Will it become K index 15, 50, 60? When will that happen?
Yes, sir. Size of the...
Sir, actually these morphology...
No, I agree with removing, but there are different opinions on how to approach this region. I was shocked. I was thinking that we will remove it, but he just write it off and said, you don't need to worry. If at all you are having symptoms, we'll manage with long-acting
KI index, you got it with the biopsy.
After the biopsy, after the resection.
After the resection.
After the resection.
You can take a biopsy earlier.
I didn't take actually. No,
Actually, the neuroendocrine tumors, the KI index never, it doesn't become benign to malignant later on. It is malignant from, if it is malignant or a high KI index with metastatic potential, it is like that from beginning. A KI index of 1, after some time it doesn't become cancer later. Sometimes
Actually, there are no longitudinal studies that.
No, it is done. It is very clearly mentioned.
Amol's team does regularly, they remove all NETs, sir. Whatever they have some Korean study or something, I don't know. But all NETs in the D1, they remove.
There is,
but in this patient, sir, the chromogranin, I don't think, whether the patient, with the chromogranin of 208, the patient should have been on a PPA.
Yeah, it can be false positive also.
Because no diarrhea. Oh, we'll go on to the next case.
Thank you.
Yes,
Oh, one more question.
Yeah, small comment. Congratulations, Arvind and Mahadevan sir, for the wonderful thing. Had your hearts on your mouth while doing the procedure. So I have a small comment. Serum chromogranin, you have to check it off PPI. Hope it was done off PPI. Usually 2 weeks of off PPI, we need to check it. And what are the electrosurgical settings you use? Electrosurgical settings.
It was endocut 2, sir.
No, this is YO3, effect 2 actually. Effect 2. Mostly we use soft coagulation for the coagulation, no, 3. Basically the RB setting in YO3 it's different from 300D. We use actually like a standard setting. We are nothing very specific actually.
Actually, the standard setting will be 3-3-30. Effect 3 second interval 30 watts. 3-3-30.
But generally we use 2-3-4 actually.
Less better to use.
During it is better to use less effect.
Yeah, 2.
Because the wall is so thin, sometimes it can cause a delayed perforation. But anyway, closure is required if patient has a very high risk of subsequent bleeding, like patients are on anticoagulant, old patient, renal failure. If you assess clinically, there is a risk of bleeding, and then those patients require closure. Otherwise, even if you leave it like that, it will heal within 1 or 2 weeks time. So without wasting, I think we can go to the next case. Yeah.
Thank you, Arvind.
Thank you.
So next case is going to be a case of bleeding per rectum. A diagnostic. Yeah. Next case is going to be bleeding per rectum, a diagnostic dilemma by Dr. Stephen from Department of Medical Gastroenterology, KMC.
Good evening, everyone. Today I am presenting a case of a 28-year-old male who is a migrant manual laborer from North India, who presented to us with complaints of a bleeding per rectum for 4 months and straining during defecation for 3 months. His bleeding per rectum, his complaint as streaks of blood coating the stool, which was bright red in color. It was associated with mild perineal pain during defecation. There was also mucus present in the stool, but he never complained of any dripping of blood into the toilet bowl after defecation. Almost about 1 month after the onset of bleeding per rectum, he started complaining of straining during defecation. His stool frequency was apparently normal, about 5 to 6 episodes per week, with the normal Bristol stool form scale type 4. He often complained of a feeling of incomplete evacuation. But almost about 1 month after the onset of this symptom, he started complaining of a change in caliber of his stools, like he is passing pencil-like stools. No history of any digital evacuation of stools, urgency, nocturnal symptoms, no history of any mass protruding per rectum. He never complained of any fever, pain, abdomen, no history of any trauma, no loss of appetite, but he complained of a loss of weight about 3 to 4 kg over 4 months, which was actually significant. No significant past history, no significant personal history, patient denies any high-risk sexual behavior, no significant family history. Patient took treatment for the above-mentioned complaints from a local practitioner and in the form of laxative. And he was also given a course of antibiotics and was also advised sitz bath. But his complaints still persisted, and for that he consulted us, our hospital. We took a detailed clinical history, we did an examination. The general physical examination came out to be normal. He was vitally stable. His per-abdominal examination was also found to be normal. But when we did a digital per-rectal examination, we found a circumferential indurated tender mucosa about 3 centimeters from anal verge, with no blood staining of the gloved finger and only normal fecal staining of the gloved finger, and the other system examination was found to be normal. Based on the above clinical history and general physical examination, we formed the following differentials, being anorectal malignancy, SRUS, proctitis, which could be infective or inflammatory. We investigated the patient accordingly. Almost all the routine investigations of the patient came out to be normal, including the viral markers, and VDRL was also negative. The stool routine examination revealed a few pustules, 4 to 6 per high power field, some mucus, no ova, cyst or parasite, and the stool culture also did not grew any organisms. We did a colonoscopy for the patient. It revealed an inflamed circumferential edematous friable mucosa starting just beyond the anal verge, extending about 7 cm approximately. Biopsy was taken and the rest of the visualized mucosa up to terminal ileum was found to be normal. This was the colonoscopic image of the lesions. This being the white line, this being from the narrow band imaging. While we awaited for the histopathology report, we did an imaging for the patient, and the MRI pelvis of the patient revealed mucosal thickening in both anterior and posterior walls involving the upper anal canal and distal rectum. The histopathology report came for the patient and it revealed the presence of phagocytic trophozoites and granulation tissue, and the pathologist gave the impression of severe proctitis with ulcerated mucosa secondary to active amoebiasis with no evidence of IBD, no evidence of malignancy. This was the slide, and this were the trophozoites that were present. We proceeded accordingly to the treatment regime. We gave the patient metronidazole for 10 days followed by diloxanate furoate for 5 days, and patient was asked to review after 2 weeks. On follow-up after 2 weeks, his symptoms did not improve, it actually in fact worsened. We again did examine the case, and this time on rectal examination, we find a circumferential tender hard mass about 2 cm from the anal verge, and there was also blood staining of the gloved fingers. We again did a colonoscopy with the patient, and this time a circumferential ediviral friable growth was seen starting just beyond the anal verge, extending about 7 cm approximately, with the rest of the visualized mucosa appearing normal. Biopsy was again taken, and this was the colonoscopic image of the lesion. While we awaited for the histopathology report, we did an imaging for the patient and CCT abdomen and pelvis with IV and rectal contrast. This time, the image picked up a circumferential wall thickening involving the rectum for a length of about 5.3 cm and thickness 12 mm, causing significant luminal narrowing with presence of perirectal fat stranding and the loss of fat plane between rectum and prostate. And the lesion was seen starting about 1.5 cm from anal verge, and the radiologist gave the possibility of a neoplastic etiology. This is the radiology image. This is the narrowed rectal lumen with thickened rectal wall. Narrowed rectal lumen, thickened rectal wall. This being the prostate, and this being the loss of fat plane between the rectum and prostate. We got the histopathology report, and this time it came with the presence of atypical cells with abundant extravasated mucin, suggestive of adenocarcinoma moderately differentiated, with mucinous and query-signet ring cell features, with no parasites, no granuloma. This was the histopathology slide, which is actually showing the presence of multiple atypical cells in high power field, the same being in the low power field. We did a CCD test for the patient, which came out to be normal. A CEA was done with a value of 8.57, the normal being less than 3. Finally, we diagnosed the patient as adenocarcinoma rectum, TNM staging, T4A, N0, M0, stage, clinical staging stage 2B with superadded amoebic proctitis, which was treated. When we searched for a review of literature, in fact, we were not able to find very many cases where the carcinoma colorectum was found associated with amoebiasis, but few cases were also reported. And in this case was actually reported from the Dayanand Medical College, Ludhiana, in which the patient presented to them with imaging feature suggestive of a rectosigmoid mass. They did a colonoscopy. A rectosigmoid mass of size 4 into 5 centimeter was seen. Biopsy was taken along with the rectal brushings, as they were not able to negotiate beyond. The biopsy proved adenocarcinoma, but the rectal brushings show the presence of trophozoites with erythrophagocytosis. This case reported from France, in which European with a travel history to Nepal 1 year before presented to the clinician with complaints of right lower quadrant pain with diarrhea. They did an imaging. They were able to see only the wall thickenings in ascending colon and cecum. They did a colonoscopy for the patient. Colonoscopy revealed the presence of multiple tumor-like lesions of size ranging between 0.8 to 3 cm in ascending colon. It was about 10 in number, with the presence of a mass 5 into 4 cm in cecum. They took biopsy from both. The ascending colon mass revealed only the presence of amoeboma, and the cecum mass revealed the presence of adenocarcinoma with superadded amoebiasis. In this case, the third case, which was reported from New York, in this the patient presented with similar complaints to our patient only, like straining during defecation. They did an examination, revealed on digital per rectal examination they were able to get only a rectal mass only. They did a colonoscopy, and in their colonoscopy they were able to see multiple ulcers in cecum along with a mass in rectum. They took biopsy, came out to be amoeboma. But this case they treated the patient little bit more aggressively. They gave metronidazole for 4 weeks, and after that they did a real colonoscopy for the patient, and they found that all the lesions, including the rectal mass, actually resolved while they look for the real colonoscopy. Now our patient is undergoing neoadjuvant chemotherapy for downstaging the disease, since it is a locally advanced rectal carcinoma, and the patient is planned for surgery after assessing his response to the neoadjuvant therapy. Most probably it could be an APR, abdominal perineal resection, because the lesion is starting about 1.5 centimeter from the anal verge, and a permanent colostomy bag is expected for the patient most likely. The take-home message: clinical medicine cannot be substituted. After taking a detailed history, clinical examining the patient, from the very beginning, one of our first differential diagnosis was rectal malignancy only, and it came out to be true at the very end. Isolated amoebic proctitis is extremely rare. Whatever case reports we have studied, almost all the cases were having proctocolitis. But in our case, even after doing colonoscopy, both times we were not able to see any lesions in cecum or ascending colon. We were actually able to see lesions only in rectum only. So isolated proctitis, if it's actually rare only, and we were not able to see that many cases of isolated amoebic proctitis. The real endoscopy after treating intestinal amoebiasis is advisable if the patient is not improving. In our case, to be frank, we get a clear-cut histopathological diagnosis of invasive amoebiasis. We treated the patient according to the protocol, but the patient did not improve. And according to many studies, even studies conducted in India by Devendra Bansal et al. From PGI Chandigarh, the drug resistance to amoebiasis is not that much of a significant problem in India till now. So if the patient is not improving, we need to think about the other possible diagnosis. Chronic inflammation versus neoplasm is always a diagnostic challenge for pathologists. We discuss our case with the panel of pathologists, and they were under the impression that the presence of chronic inflammation and the presence of granulation tissue, which were there in our case from the very beginning, might obscure the findings of neoplasm. So after we treated our case for the cause of chronic inflammation, which was amoebiasis, these obscured findings which were not there, it actually got cleared up, and the pathologists were able to pick up adenocarcinoma very easily. And to conclude, the young age colorectal carcinoma is on the rise, so we cannot keep age as a cutoff. Even a study done by Gaurav Patel et al., which was published in Indian Journal of Surgical Oncology in 2022, the study is clearly showing an epidemiological data that the young age colorectal carcinoma is on the rise. So age for our side cannot be taken as a mandate. Thank you.
Just one question.
Sir.
Very nice presentation, very interesting also. But if you have taken more biopsy, do you think the pathologist would have picked up the carcinoma also?
Sir, we thought like that also, sir.
Because you must have taken biopsy only from that ulcerated lesion, and then probably the depth was not there. I'm just conjuncturing. I'm nothing against you, but I'm asking you if more biopsies, deep biopsies were taken, since you had the malignancy as the first possibility.
Yes, sir.
Could that have been picked up in the first try? Because you had to wait for 3 weeks before you
had another scopy and then had a biopsy.
Yes, sir, exactly, sir. But we, according to, we actually took a sufficient biopsy, that too deep biopsies. But the slides which the pathologist examined might be having that granulation tissue and were having that chronic inflammation. Might be that. We cannot.
Agree. But inflammation masks that, but
Yes, sir.
more deeper biopsies maybe could have picked up.
In the rectal examination,
Yes, sir.
after 2 weeks or 3 weeks, the mass become hard.
Yes, sir.
Initially it wasn't. How can a cancer become hard in 3 weeks time? Did it be like that first time also?
Sir, it was actually indurated mucosa when we examined the patient the very first time, sir. But that's why when we did an examination the very next time, then we got more suspicious because it was a clear-cut hard mass. That is circumferential hard mass also.
The last thing is, I would like to make a comment that the MRI, you should have discussed the MRI. There is no way within 2 weeks there is going to be serosal infiltration.
Yes,
And within 2 weeks you cannot, from the mucosa, it is not going to go to the serosa. So
Yes,
first of all, it is a misdiagnosis of the
It cannot be T4A in 2 weeks.
Yes, sir. That's what we also.
But it has been there earlier also.
Okay, thank you.
Thank you, sir.
Oh, sorry sir, sorry sir.
Sometimes in the lower rectal lesions, instead of in addition to a colonoscopic biopsy, you can also put a proctoscope and take a punch biopsy.
Initially, we also had a similar discussion with the surgical gastroenterologist to examine under anesthesia and take a punch biopsy. That was initially decided, but by that time, I think we arrived at a diagnosis.
Okay, thank you. So now we will call upon Dr. Pranav from Stanley to present about hilar cholangio. Gallbladder carcinoma.
Good evening, everyone. Today I'll be presenting the seminar on gallbladder carcinoma and a review of Indian literature. I would like to thank my moderator, Dr. B. Sumati, and TNISG for giving me this opportunity. I'll be discussing this review under following headings: epidemiology and risk factor, pathophysiology and clinical features, investigations, management, and any deficiencies in and future directions. Now, the gallbladder carcinoma is the most common biliary tract cancer worldwide, and its epidemiology is highly variable across different regions of the world. And approximately 2/3 of cases of gallbladder carcinoma, they are diagnosed either during surgery or post-operatively. Now, this is the world map which is showing the incidence of gallbladder carcinoma in various regions of the world. From here we can see that India has one of the highest incidence rates of gallbladder carcinoma, along with certain Western countries like South American countries like Chile, and also some Eastern countries like Poland are also having a high incidence of gallbladder carcinoma. Now, in India, according to ICMR data of 2020, the gallbladder carcinoma is 2 times higher in women than in men, and the incidence decreases after the age of 45 years and is maximum at the age of 65 years. And among the proportion of the GI cancers, gallbladder carcinoma is third only to esophagus and the stomach carcinoma in the overall proportion of the GI cancers. Also, within India, the geography plays an important role, and the incidence of gallbladder carcinoma is highly variable, with the maximum proportion of the cases being from North India and Northeast India, with the rates of 16.2 per 1 lakh, while in South India, the rates are very less at 1.7 per 1 lakh population. Recent studies have been done in both North and South India for regarding the trends of gallbladder carcinoma, and they have concluded that the overall incidence has been rising over past 3 decades, with the incidence rates of 6.2 per 1 lakh in 2001 to the current incidence rates of 16.2 per 1 lakh in 2020. However, it must be noted that many of these studies have concluded that the mean annual percentage change of gallbladder carcinoma incidence is highest in South and Western India as compared to the North Indian population. The risk factors, coming to risk factors for gallbladder carcinoma, a recent study conducted in AIIMS New Delhi, it concluded that residence in a gangetic area, ingestion of fried foods, interval between the meals of more than 8 hours, any chemical exposure, joint type of family, history of tobacco use, and a family history of gallstones were significantly associated with higher odds ratio of developing gallbladder carcinoma, while tea and coffee ingestion, it was associated with the low rates of gallbladder CA. This is a map of India which is showing the various regions in the India where the gallbladder carcinoma shows a high incidence rates. As we can see, the majority of the India, the North Indian population, especially along the Indo-Gangetic belt, has a high incidence of gallbladder CA, while some parts of central as well as the western India in Maharashtra also have reported a high incidence of gallbladder carcinoma. Now, several theories have been postulated as to why this Indo-Gangetic region has a high incidence of gallbladder CA, and many studies they have concluded that towards the east, the pollutant concentration as well as the bacterial contamination, they have been found to steadily rise, and the fecal coliform count has also been found to steadily rise towards the east. Added to this, untreated sewage, industrial waste and agricultural effluents, they get added along the river along its course. And since this region especially has a very high population density and very poor population which relies predominantly on river water for its daily needs, hence they are accidentally exposed to these chemical toxins and carcinogens. Now, whether the place of birth has any association with the risk of gallbladder was explored in a recent study conducted in Tata Memorial Hospital, where they concluded that the risk was higher in those who were born in high-risk areas versus the low-risk areas. And the GB incidence was more often found in patients who had migrated from high-risk areas versus the natural residents of the disease. And the risk increased with the increase in duration of residence in the high-risk region. And the increase was high even if the population had migrated back to the low-risk region after staying for a while in a high-risk region. Also, they concluded that Indians who were migrating to other countries carried a high risk for gallbladder carcinoma than the native population. Now, the average age of diagnosis of gallbladder carcinoma is 2 decades earlier as compared to the West, and this has been explored in many Indian studies. And the female is to male ratio, it varies from 3:1 to 4.5:1 in various Indian series. While, however, a study conducted in southern part of India, it found that male population in the southern part of India was more susceptible to the gallbladder carcinoma with a ratio of 1.6:1. Now, gallstones have been implicated as an important pre-malignant factor for gallbladder carcinoma, and the incidence of gallbladder stones is 20 times higher in North India versus South India. In North India, predominantly the cholesterol and mixed stones are found, while in South India, the pigment stones are predominant. And gallstone disease is usually found in up to 70 to 90% of patients with gallbladder carcinoma. However, it must be noted that the incidence of gallbladder carcinoma is out of proportion to the prevalence of gallbladder disease, and hence other factors like chemical toxins and genetic factors should also play a role in the pathogenicity. Various ecological studies have been done in the northern parts of India, where they have concluded that high levels of pesticides and heavy metals and nitrates, they have been identified as pollutants in the Ganges. And a study conducted in SGPJ Lucknow, where they measured the levels of metal concentration in the carcinoma of gallbladder, it found that the patients who were having gallbladder carcinoma with gallstone disease had a higher concentration levels of cadmium, chromium and lead when they compared to the controls of standard gallstone disease patients. Now, infections are also an important risk factor for gallbladder carcinoma, especially the infections with the chronic Salmonella typhi and H. pylori have been studied in various Indian series, and majority of them have found that presence of any of these two infections is associated with the increased odds ratio of developing gallbladder CA from 2.7 to 12 than the general population. And chronic inflammation of the gallbladder carcinoma has been kept as a key pathogenetic mechanism for the infections. Now, genetics seem to play an important role, with P53 mutation being the dominant pathway for the disease. And a study done from AIIMS New Delhi, where they found that where they studied the fragile histidine gene, which is a tumor suppressor gene located in chromosome 3p, and they found that there was an increased loss of heterogeneity and microsatellite instability of this gene in the gallbladder carcinoma. And when they compared this with the gallbladder with the xanthochromatosis cholecystitis and chronic cholecystitis patient, the frequency was significantly different than these two chronic conditions. Also, studies have been done on progesterone receptors and their role in gallbladder carcinoma. And they have found that the higher expression of estrogen and progesterone receptors both are found in gallbladder CA. However, progesterone receptor expression is associated with a higher survival rates than compared to the expression of estrogen receptor in gallbladder carcinoma. Similarly, some other authors, they have conducted studies on various receptors like complement receptor 1, caspase 8, and polymorphism in DNA repair genes like ERCC2, MSH2, and OGG1, and they have found that these are associated with a significantly higher risk of developing gallbladder CA. Other risk factors, they include low BMI, high parity, rural residence, residence in a low socioeconomic status, and smoking, and these have been correlated in various Indian studies. However, factors like oral contraceptive pills, methyl dopa, isoniazid, and structural breathing abnormalities and aflatoxins, they have not been studied very well in Indian literature. Coming to the pathogenesis, now a recent pathogenesis for the Indian population was recently proposed by Dr. Usha Datta from PJ Chandigarh, in which they proposed that the risk factors for gallstone disease are already present in the Indian population and susceptible population, like genetic mutations, CYP polymorphisms, Asian ethnicity, and family history of gallstones, and dietary factors like a high fat, high carbohydrate diet and a low protein diet, and associated micronutrient deficiency, they predispose a patient to development of gallstone disease. Now, in India, majority of the symptomatic patients, they seek either local medications or home-based care, and the asymptomatic patients, they are not screened due to a lack of screening program. Hence, the disease remains per se in the gallbladder, and it leads to a chronic inflammation and irritation in the gallbladder. Now, the triad of chronic inflammation and irritation with infections like Salmonella and H. pylori, and exposure to chemical toxins like nickel, cadmium, and smoking, they lead to mutations, especially in the P53 pathway, which triggers a metaplasia and dysplasia sequence. And since gallbladder carcinoma, it does not present in initial stages, and there is no screening program in the Indian literature, hence the disease progresses over time and ultimately presents as a fulminant gallbladder carcinoma. Now, coming to the clinical features of the disease, the presentation of gallbladder carcinoma has usually three situations. It can present as an advanced form, which is the most common form of presentation and is usually inoperable at that time. It can present as a mass lesion in gallbladder, which is usually seen on radiologically, or it can be detected incidentally when gallbladder has been resected for any other condition and has been diagnosed on histopathological examination only. The diagnosis, according to ICMR, the diagnosis of gallbladder CA should be kept as obvious when the diagnosis is apparent on examination and imaging. It should be kept as suspicious GBCA when there is a finding of focal or diffuse wall thickening or a small polypoidal lesion is found on imaging. And it should be kept as incidental gallbladder carcinoma when it has been found only on routine histopathological examination of an unsuspected cholecystectomy specimen. Now, the presentation of gallbladder carcinoma has been studied in some studies, and there are some differences between the northern and the southern Indian population. In north, majority of the male is to female ratio is 0.36:1, and the age of diagnosis is around 51 years, while in south, the studies have been done where they concluded that male is to female ratio was 1:1.6:1. In the northern Indian population, pain, jaundice, and hepatomegaly are the most common complaints with which the patient came, while in southern Indian population, pain, jaundice, and a palpable GB mass was found to be more common form of presentation of the disease. Now, coming to the investigations, now gallbladder carcinoma usually presents late in the investigations, and general blood investigations are usually not helpful. Coming to tumor markers, no specific tumor markers have been currently approved for gallbladder carcinoma. Cancer antigens are mainly used in the disease, but they have not been validated in wide population-based studies. And CA99 levels are usually higher in patients with gallbladder carcinoma, and sensitivity and specificity for diagnosing the GBCA have been found to be 71% and 96% respectively. Another cancer antigen, which is CA242, which is not affected by any inflammatory disorders, has been studied in some Western literature, and the specificity for diagnosing gallbladder CA has been found to be 98.7%. Coming to the radiological investigation, now ultrasound is the most common initial investigation of choice for gallbladder carcinoma, considering its high sensitivity for diagnosing a local regional disease with a sensitivity of around 85% and a diagnostic accuracy of about 80% in the staging of gallbladder carcinoma. However, it must be noted that ultrasound fails to detect subtle lesions and which are usually flat, and also it can fail to detect sometimes the larger lesions like when a GB is filled with various calculi. Also, ultrasound is inadequate to differentiate between the mural thickening, which is associated with cholecystitis, and gallbladder carcinoma. These are the various presentations which can be seen on ultrasound. The gallbladder carcinoma can either present as a mass replacing lesion, or it can present as a polypoidal lesion. And presence of an asymmetrical irregular wall thickening and thickness of more than 1 centimeter should raise the suspicion of gallbladder carcinoma on ultrasound. Also, a polyp of more than 1 centimeter should raise the suspicion. However, it must be noted that two malignant polyps constitute only about 0.6% of the total of gallbladder CA. Now, to better stratify the risk of detection of wall thickening in ultrasound, a system was proposed which is known as the GB-RAD system. Now, according to this, the GB-RAD system has 5 classifications, with 1 being the normal finding, and at the GB-RAD score of 5, malignancy is considered to be highly likely. The GB-RAD score of 1 is given when the gallbladder has an adequate gallbladder distension, and with the wall thickening is less than usually of 3 millimeter in size. And malignancy is considered to be highly likely when there is a circumferential focal wall thickening and with the loss of interface with the liver parenchyma. And the probability of malignancy from GB1 to GB5 ranges from a benign disease at GB2 of less than 2% to more than 90% at GB5, GB-RAD score of 5. Now, coming to the CT abdomen, CT abdomen is the standard investigation for detecting and staging of gallbladder carcinoma, and it can be used to quantify the volume of feature liver remnant, identify anatomical variations of the vessels. It is usually done in 2 phases. One is the arterial phase, which is done as 25 to 30 seconds, with the second phase of portal venous phase done at 70 seconds. The arterial phase can be used to detect the various arterial anomalies before the surgery, while the portal venous phase is usually done to know the extent of the primary tumor or any infiltration into the portal vein, local organ, or lymph nodes, and to also see the various metastases like liver, peritoneal, or distant metastasis. Now, gallbladder carcinoma on CT can also present like similar features on ultrasound. Either it can present as a mass lesion, or it can present as a wall thickening, or it can present as an intraluminal polypoidal lesion. So the differential diagnosis of CT on are like for focal and diffuse thickening, differential diagnosis of granulomatous cholecystitis, adenomatosis, and acute cholecystitis with pericolic abscess must be kept, which usually mimics a stage 3A tumor. While the intraluminal mass can be either a polyp or a carcinoid or a multiple myeloma. And a mass replacing gallbladder can be either a hepatocellular carcinoma or a metastatic to gallbladder. Now, MRI has not been studied well in Indian literature, and it is usually less frequently used for staging of the disease. MRCP has been found to be has a better definition of the hilar involvement than the GB carcinoma. And a study done in West found that MRI plus MRCP with dynamic contrast had an accuracy of 84% for determining the T stage of the disease. Gallbladder carcinoma usually presents as a hypointense lesion on T1 and a hyperintense lesion on T2 weighted images. Coming to the role of endo-ultrasound. Now, endo-ultrasound has been recently effective in diagnosing gallbladder carcinoma patients, and it is superior to transabdominal ultrasound. And usually the appearance of gallbladder on endo-ultrasound is two-layered, with the inner hypoechoic layer and the outer hyperechoic layer. Studies on endo-ultrasound versus transabdominal ultrasound in Indian literature are lacking. However, a meta-analysis done in West found that there was no significant difference between diagnostic accuracies of endo-ultrasound versus HRUS and multi-director CT in diagnosing early lesions of gallbladder carcinoma. Various scoring systems have been developed in the Western literature, but none have been studied in Indian literature. A scoring system by Sadamoto and al. It found that maximum diameter in mm with internal echo pattern score and a hypoechoic spot score with a cutoff of 12 had a sensitivity and specificity for diagnosing benign versus malignant lesions of 77 and 82% respectively. While a study similar score by Choi et al. For lesions of 5 to 15 mm in size, where they took the layer structure, echo patterns, polyp margin and presence of stalk, and a cutoff score of 6 was kept, and they could diagnose, they could differentiate the benign versus malignant lesion with a sensitivity and specificity of 81%. Endo-ultrasound can also be used for staging of gallbladder CA, and the differentiation between early and advanced stage using ultrasound has a 79% accuracy, and the overall accuracy for diagnosing the depth of tumor invasion is around 76%. A study was conducted in the West where they tried to correlate the histological staging of gallbladder carcinoma with the endo-ultrasound findings, but Indian literature is lacking, and they concluded that pedunculated GB carcinoma could be correlated well with a T1 in situ or a T1 mucosal depth of invasion. A sessile gallbladder carcinoma with an irregular outer hyperechoic layer was correlating well with the with the SS invasion, and if outer hyperechoic layer was retained, then the differentiation was not possible. USFNA has a very high diagnostic accuracy with sensitivity, specificity and diagnostic accuracy of up to 100%, and the presence of heterogeneous enhancement had a sensitivity for diagnosing gallbladder CA of 94%. Now coming to preventive measures, there is no consensus, society-wide consensus for preventive cholecystectomy of gallbladder carcinoma. However, ICMR consensus of 2011, it states that...
Pranav,
yes,
you
sir.
come to conclusions later.
Yes, sir.
Already 7 o'clock.
Okay, sir. The preventive cholecystectomy should be considered for symptomatic cholelithiasis.
Come to the conclusion.
Yes, sir. Yes, sir. Now, what deficiency which we could find in the literature were that disease active pathogenesis has not been, final slide only, sir. Yes. Has not been studied well in the literature.
Summarize the treatment in one slide. You can summarize your treatment in one slide, because everybody is more concerned about the treatment in one slide.
So for the loco-regional treatment for incidental diagnosed gallbladder carcinoma, so these are taken from the ESMO guidelines which have been adopted for Indian population. And for incidental diagnosed gallbladder carcinoma, a reoperation with radical intent should be done, and a resection of segment 4B and 5 should be done with the lymphadenectomy of the hepatoduodenal ligament. For advanced cases, first line therapy with cisplatin, gemcitabine and durvalumab, while alternative therapy with cisplatin and gemcitabine should be kept. And for second line therapy, Folfox regime should be done, and irinotecan based therapy can also be used. For adjuvant cases, S1 based chemotherapy or capecitabine based chemotherapy should be done, and for selective cases with R1 resection, subsequent RT or CRT may be considered. For surveillance and follow-up, 8 to 12 weeks of follow-up should be done, and in addition to imaging, CA99 should be included in the follow-up. For biliary obstruction, biliary drainage with PTBD or a metallic stent should be done if expectancy of the patient is more than 3 months. And once the resection has been done, then surveillance for recurrence should be done at 3 to 6 monthly for first 2 years, and 6 to 12 monthly for the next 5 years. And a study done by PGI Chandigarh, where they studied the outcomes of SEMS with PTBD for gallbladder carcinoma patients, they concluded that simultaneous percutaneous drainage with SEMS had a moderate clinical success and a 6-month patency in almost half of the patient, and they suggested that this must be considered for palliation. The deficiencies were disease pathogenesis have not been studied well. Molecular and genetic studies are lacking in India. Tumor markers need to be explored in the Indian literature, and studies on the role of US are still not started in Indian studies. There are no indication for staging laparotomy for the Indian population. No role of neoadjuvant therapy. No centralization of treatment policies in GB carcinoma. And consensus should be developed on preventive cholecystectomy for asymptomatic gallstones. and for best treatment follow-up, and for future role of AI and neural models for early detection of the lesion should be done. Thank you.
Dr. Babunish to present the certificate of appreciation right now. Faranullah. Okay. Stephen Alexander. Arvind, you can exchange it. Yes, yes, yes.
I thank all the postgraduates who are presented and the chairpersons for their comments as well. It was a wonderful presentation. I hope the same gets written up as an article and you send it out to our journal as well. We begin this meeting again with a word of congratulations to Professor T.S. Chandrasekhar and MedIndia unit for conducting a beautiful e-meeting with the legendary Nobel Prize winner, Professor Barry Marshall, on 25th of September. I think we had a very good interaction with and a nice lecture by Dr. Barry Marshall. And it's also very heartening to note that among the medical gastroenterology fraternity, about subject-wise ranking the top 2% scientists in the world, and those who will come in that list, I think we have about 8 or 10 of us from India, out of which one of them is Dr. Ramakrishna. It's really wonderful. He's not here. I think to do for a big round of applause. And we're also, you can see that the number of publications and the time they have started publishing, it's right from 70s and 80s, and they're still a lot ongoing. They're publishing, and they have the numbers of publications are like in 500. Dr. Shireen has about 500 publications. Dr. Rakesh Agarwal has about 260. It's really wonderful, and I hope some of us can match it in the coming years. Coming to the multi-center study, role of Plex in ALF and ACLF, I think it's nearing completion and data collection is over. I think it will be hopefully Dr. Alagamai will be able to write it up and probably they might even present in a midterm ISG. And the next upcoming study from Tamil Nadu ISG will be a multi-center study which will focus on possibly the clinical epidemiological features of hepatocellular cancer. I think the proforma is probably getting ready, and Dr. Sumati, when she's around next time, probably she'll be able to share with us as to what is the proforma that we are going to do. And as I discussed, this is on upcoming meeting that is on 2nd October, so holiday on the evening 7 to 8, and it will include 2 case presentations by postgraduates and a lecture by Dr. Rakesh Agarwal on how to approach and how to criticize study in gastroenterology. I think it will be of good use to all the postgraduates, and definitely please make use of this opportunity. The next thing is our midterm meeting, which is coming up on October 19th and 20th at Kutralam, very nice venue. Dr. Kandasamy has been taking a lot of efforts and painstaking efforts from their side to organize this meeting. Please make your travel arrangements. Those who are registered will get their accommodation also. I encourage all the postgraduates to kindly submit their abstracts. Till last weekend, we had only about 9 abstracts. Hopefully the numbers go up, and there'll be poster presentations, and there'll be 3 prizes for the top 3 poster presentations. And there's also a quiz competition for the postgraduates from all the colleges. So please do participate. The next annual ISG meeting is on February 20. Tamil Nadu ISG meeting will be on February 22nd and 23rd at Coimbatore. Please mark the dates. Subsequently, we will be starting the work for the meeting after the midterm ISG is over. And National ISG Con will be on from December 4th to 7th at Varanasi. That's about it. And please take a minute of your time to scan and fill up the details. We are working on getting the pending TNMC points. There are some problem that the TNMC portal, which is getting sorted out. So in the next couple of months, we should be able to get whatever pending TNMC credit points that we are due for. Thank you so much. Now I'll request the chairpersons for our CME. And there's one more, the ISG voting session is started from today. It will go on for the next 2 weeks. I think most of you who have been ISG members would have got their email as well as SMS, I think, to your phone number as well. And from Tamil Nadu ISG, Dr. Mohan Prasad's daughter, Dr. Madhura, is contesting for the post of General Council member, County Council member. So please do support so that we have one more representation from Tamil Nadu ISG for the National Body Governing Council. So please take your time to please submit your vote as well. So moving on to the next part of our meeting, the CME on liver diseases. I request the chairpersons, Dr. Shanti Vijayaraghavan, professor from SRMC, and Dr. Vimal Raj Velayudam, senior liver transplant surgeon from Miyot Hospitals, to come out to the dais and conduct the proceedings, please.
Good evening, all. First, we would like to invite Dr. Vijay Alexander, Assistant Professor, Department of Hepatology, CMC Vellore, to deliver his talk on plasma exchange in liver diseases, indications, techniques, and results.
Good evening. I thank the society for this invitation to talk on plasma exchange in liver disease. I will keep it short. Plex in liver disease per se is actually quite a broad topic, and to cover that in 30 minutes would be quite a challenge. So we'll try and stick to some relevant things, and specifically the things that were mentioned were indications, contraindications, and the technique of doing it, and a little bit on results. So I'll try to stick to the relevant bits, and I'll try to, if you come across anything that I say as controversial, then I apologize for that in advance. Sure. So a brief overview would be on what Plex is, where this plasma exchange figure in the management algorithm for liver failure, and I'll briefly touch upon what the CMC experience so far has been. Where this plasma exchange comes specifically in rodenticidal hepatotoxicity, what the protocol we follow at Vellore is, and I'll summarize with that. So plasma exchange involves the removal of plasma, which is plasmapheresis, followed by replacement. So this entire process would make it plasma exchange, and it's quite self-explanatory. The replacement fluid in liver diseases that is routinely used is FFP, and it's usually volume matched fresh frozen plasma. There are other replacement fluids as well, but most centers and most studies that have looked at plasma exchange for liver indications have used FFP as the replacement fluid. Going on to this is probably the controversial bit, and this is what I'm trying to, what everybody has been trying to figure out, where does Plex figure in the management algorithm of liver failure. So when I was doing my MD medicine, if someone were to tell me plasma exchange, things that would come to my mind would be GBS, thrombotic microangiopathy, and things like that. And that is what plasma exchange, antibody mediated diseases, where removal of the antibody would sort of ameliorate the severity of the illness, is routinely where or classically where plasma exchange has been utilized for management. Newer indications, actually it's not a newer indication anymore. Plasma exchange has been used for liver indications for more than a decade. and this would be in liver failure situations, which is ALF and ACLF. This is the American Society for Apheresis guidelines, which says that high volume plasma exchange is first line treatment as a standalone treatment or in combination with other things for acute liver failure, and there's more to it. Now coming to what volume of plasma exchange should be used, again highly controversial. There's high volume, standard volume and low volume, which has been sort of rather loosely used around in literature, in the sense that there's no clear definition as to what these are. And I would try and allude to some studies which have used these volumes. So high volume, the landmark study is the Larsen study. I'll briefly touch upon that. And they used about 4 times the calculated plasma volume per session. So that's about 8 to 12 liters of plasma that's exchanged, and that's huge. Standard volume, it can be anywhere from 1 volume equivalent to up to 2 times, and one of the studies that is used is this Dr. Rakhi Mewal's study from ILBS, and then there's low volume plasma exchange, which we have been sort of following, and that's 50% of calculated plasma volume, which would come to about 1.2 to 1.4 liters per session. High volume plasma exchange, this is the study that I was talking about previously. This is the Larsen study, and the box here is the Kaplan's formula, which is used for calculation of estimated plasma volume, which is about 65% of your body weight, and subtract the hematocrit from that. This RCT involved 13 European centers, and as I mentioned, it was 4 times the calculated plasma volume, which is about 8 to 12 liters per session. So 92 underwent Plex and 90 underwent standard treatment, and the difference in survival, transplant-free survival, was 58% and 47%. Standard volume plasma exchange, this is the ILBS study, and this is again an RCT. Standard volume Plex, which was about 1.5 to 2 times the calculated plasma volume, 20, and sorry, one thing I forgot to mention was the predominant etiology in the Larsen study was paracetamol, ALF. And here, this was mostly viral etiology and again ALF. And the survival was somewhere between 75% in the plasma exchange group and 45% in the standard medical treatment arm. This is not an RCT, this is a cohort study from CMC, which has looked at idiosyncratic DILI. I'll just draw your attention to this last line, where 1 month survival was about 60% in patients who were managed with Plex alone. We know that idiosyncratic DILI resulting in ALF portends a very poor prognosis. So about 22 patients were there in this group, and about 60% of them were alive at 1 month. So in CMC, Plex started in 2016, and so far the numbers have crossed somewhere around 650, and the annual numbers are somewhere around 90 to 100 plasma exchange per day. Per month, per year. Okay. I'll now move on to how do we choose an urgent treatment modality for acute liver failure. So far I've been talking only about acute liver failure. So the first question is, do we have access to liver transplant? If so, what is the predominant program that's available? Is it a live donor program or is it a deceased donor program? If it is a deceased donor program with the availability of organs at a very short time, then the obvious choice for ALF for those people who meet listing criteria would be super-urgent listing and transplantation. If there is the availability of an organ and LDLT is possible, then for those people meeting listing criteria, again the treatment of choice is LDLT and super-urgent transplant. For those people who don't have these options, then the options become standard medical treatment and plasma exchange, and we will see that more and more people with Plex and not getting access to transplant may be surviving as compared to standard medical treatment. I'm not going to specifically talk about indications of plasma exchange, but when it comes to liver, we should all be clear that we are not going to subject someone with decompensated cirrhosis to plasma exchange. The indication for plasma exchange in liver would be a liver failure syndrome. So that would be ACLF and severe ALI and ALF. The
first question that we are going to ask before we go into any of these algorithms is, does the patient meet listing criteria for transplant? Is there an indication for transplant? Then automatically that becomes the first option, because standard of care at this point of time is liver transplantation for those people meeting listing criteria. Now, for those people who don't have these options, then you explore more options and see if it is plasma exchange versus standard medical treatment. Are there indications? Are there contraindications? Are we doing more harm? Or what can they possibly be subjected to? I'll briefly touch upon rodenticidal hepatotoxicity per se. And I know that this is something that's quite close to the TNISG Society as well. And this is a study that was published from TNISG in 2019, where 6 months of patients with toxic hepatitis was looked at across 6 centers, and for 450 patients with rodenticidal hepatotoxicity, there were 6 patients with paracetamol ingestion, and that ratio was 75:1. And Dr. Epen, who is my mentor and boss, repeatedly says rodenticide is the paracetamol of South India, and in fact most of here. We really don't see paracetamol ALF at all. And in those 450 odd patients, there were 55 patients who, that is 35 patients who died or were discharged in a moribund state, and only 1 patient had liver transplant in this particular group. About 1,000 liver transplants are being done in India per year, and about under 10% of these are for acute liver failure. They do exceptionally well when they undergo transplant for liver failure, but the numbers who get there are not great. If of 450 patients, 50 odd have a poor outcome, in a year it is estimated that 1,584 patients with rodenticidal hepatotoxicity would be there, and about a third of them would have a poor outcome. That is about 500 odd patients. Then arises the need. There is a need for non-transplant treatment options, especially in resource-constrained settings. Now, question is it a standalone treatment or is it a bridge to transplant? Right. This is a listing criteria alluded to as the Kochi listing criteria. So this is from Amrita Kochi, where they looked at their cohort of patients who had rodenticidal ingestion, and they found that patients who had a MELD of more than 36, admission MELD of more than 36, or a baseline INR of more than 6 plus encephalopathy, had a 100% mortality short of a transplant. So this is commonly referred to, and the original paper did not call it Kochi criteria, but we have been increasingly calling it the Kochi listing criteria. This is briefly to touch on our experience in rodenticidal hepatotoxicity. 200 patients with rodenticidal hepatotoxicity who were admitted in our department were retrospectively looked at, and 32 patients fulfilled the Kochi listing criteria, of whom 24 were ALF and 8 were ALI, severe ALI. And the 1 month transplant-free survival in these patients managed with PLEX was 69%. That is 22 out of the 32 survived. Now, the criticism can be that we have given a lot of clauses here saying that PLEX eligible and who underwent PLEX, but the same will apply for transplant as well. But having said that, this is a small number, but of the 32 who were managed with PLEX and who met the criteria and who did not have contraindications, the survival was almost 69%. Looking at who survived and who did not, the presence of hepatic encephalopathy and a decline in MELD after the 3rd session of PLEX predicted survival. And on multivariate, we noted that it's a delta decline in MELD only which stood out. And this delta decline in MELD of more than 10% from baseline to 3rd session of PLEX had more than 90% sensitivity and specificity in predicting survival after PLEX without a transplant. I will probably keep moving for want of time. So the question is, these are the Tamil Nadu Society guidelines for plasma exchange. So when are we going to consider plasma exchange? So in patients with severe liver injury, that is when your INR is more than 4, or you see that there is serial worsening of INR on treatment. HE has not set in yet, it's just serial worsening of INR. It would be reasonable to consider plasma exchange. ALF, it is a given. First is to see if they
meet listing criteria for liver transplantation and of a plasma exchange versus transplant. There is a problem here that King's College criteria may not be the best criteria for selection of patients with rodenticidal hepatotoxicity. This has not been studied, and we do not know how good this criteria stands in patients with rodenticidal hepatotoxicity, unlike in paracetamol poisoning. This is the Tamil Nadu NHM initiative in improving survival with rodenticidal hepatotoxicity using the hub and spoke model for plasma exchange. Okay, I mentioned that plasma exchange has a role in liver failure syndromes, which is predominantly severe ALI, ALF, and then acute on chronic liver failure. I'll just touch upon our experience in acute on chronic liver failure. This was the first one which my colleague Santosh worked on, and there was, so if you look at just this table, again I agree that the numbers are small, but 1-1 survival comparing Plex to standard medical treatment. So this is with a historical cohort. This is not an RCT, was 66% versus 16%, and at 1 year was 20% and 11%. He went back and looked at what patients did better, and he found that patients who were offered centrifugal Plex did significantly better than patients who were offered membranous Plex in alcoholic ACLF. I'll just touch upon the protocol we follow at Velo, and we routinely follow a low volume plasma exchange. Okay, that is a bold statement that I've made, that it is equally as effective as high-end standard volume Plex. Our experience so far says that the outcomes have been comparable. It is not a randomized head-to-head control trial, but our general experience has been that low volumes are as good as high-end standard volume. The biggest advantage here is that it is a much less of a strain on the already strained blood bank. Now, if we are doing 5 Plex plasma exchange a day, and I'm asking for 8 to 12 liters of plasma exchange, it's not possible for the blood bank to sustain that kind of demand. So a low volume does help with that. Having said that, another very, very important thing is that there is lesser chance of transfusion-related complications, which is predominantly TRALI and TACO. TRALI not so controllable, but definitely transfusion-associated circulatory overload is much lesser with lower volumes. Excuse me. I just mentioned about centrifugal versus membranous. Why is centrifugal preferred? The flow rate is much lesser in centrifugal, and this makes it more preferable due to lesser volume fluxes, and it's assumed that the liver tolerates this much better. What are the contraindications to plasma exchange? So active untreated sepsis, that is severe SIRS, bacteremia, would be a definite contraindication to plasma exchange. Hemodynamic instability, we are already, if the patient is already on quite a bit of inotropic support, at what inotropic support do we say no plasma exchange is still not clear, but if the patient is on a bit of inotropic support and you feel that getting a flow out of your dialysis catheter is going to be difficult and going to be more detrimental to the patient, it's better not to do it. Like transplant, we do need to think about futility of care as well. Have we gone to that phase of multi-organ failure, and we really need to then sit together and think, and for each patient it has to be an individualized decision making. Standard guidelines will not apply for everybody. Complications to watch out for during Plex will be line-related complications, sepsis, transfusion-associated complications, which I just mentioned about, which is TRALI and TACO, and worsening liver dysfunction. So at any given point of time, we need to revisit the possibility of liver transplant, explore that while the patient is still undergoing Plex. On the other end, is a patient doing so poorly that he has already gone into multi-organ failure, and there are 2 or 3 organ failures, and then we are going to discuss futility as well. A general policy is that we follow a restrictive transfusion strategy. There are no prophylactic transfusions. A TEG or OTM is generally done prior to port insertion or a major procedure, and if it is quite reassuring, then no products or minimal products are used for line insertion. This is my last slide. So we generally counsel all treatment options prior to starting Plex and obtain consent for Plex. Contraindications are closely looked at, which is bleed, sepsis, severe hemodynamic instability. Port insertion, we generally prefer a femoral route, and prophylactic transfusions are avoided. Replacement fluid is always FFP. 50% of calculated plasma volume is removed and synchronously and simultaneously replaced using a centrifugal technique. Low dose steroid has been used on the days of Plex and subsequently for a few days, both in ACLF and in ALF. We generally started the day prior to starting Plex, and this is generally 10 mg of prednisolone, which is used. If the patient is intubated, then we use about an equivalent dose of hydrocort, which is about 25 milligrams IV twice daily. Prophylactic antibiotics and infection surveillance is very, very religiously and almost sacredly looked at and taken upon, and sedation as far as possible is avoided. Generally, drug list and drug list check is done daily. Nutrition is ensured and a little bit of enteral feeding, if whenever possible, is maintained. And invasive procedures on the day of Plex, if that can be avoided, is best avoided, and we do not try and shift the patient. We try not to shift the patient if, on the days of Plex, etc. And it's the work of a large team which includes hepatology, transfusion medicine, nephrology, ICUs, medicine, pediatrics, and PICU. This is my summary slide. It's still not clear as to where Plex stands in the management algorithm, but more and more evidence says that it may have a role as a standalone treatment and not just as a bridge to treatment, but it's still not standard of care yet. So that's something that we need to keep in mind. Low volume Plex has been shown to be beneficial in liver failure syndromes, both ALF and ACLF, and is much better tolerated than higher volumes. I'll probably just skip that third line, and which is what I just touched upon. Is it standalone versus a bridge? Still not clear. But for those people who do not have an option of transplant and are considered candidates for transplant, this, if it evolves as a standalone treatment, then it's going to be great. And there is increasing evidence for the safety and use of Plex. Thank you.
Thank you very much, Dr. Vijay, for, having come from the Mecca of Plex for Tamil Nadu, we can say. That was a very crisp talk. Now, any questions from the audience?
Yes, ma'am. How many sessions you generally average use? Because each session is going to be costly. It's not cheaper. It's more only 30,000 or 35,000 per session. And when will you stop the sessions? When you are going to see the?
Yes, sir. So it's only for want of time that I didn't go into that. Generally, we try and aim at 3 sessions, but it has to be an individualized decision. The need for more sessions or fewer sessions has to be decided by the treating team on the floor daily. In rodenticide per se, right now we know that it's the INR and not the bilirubin which is sort of determining the progress, but overall delta meld. So that's what we said. So more than 10% decline between day 1 and day 3, sort of after the third session, sort of tells you that, okay, patient is doing well and you can actually stop. In ACLF, Santosh's data, Santosh is my colleague who's been working on alcoholic ACLF, shows that 20% reduction in bilirubin from day 1 to day 3. Session 1 to session 3 actually predicts 1 year survival. So again, those are not things that I went into, but it's mostly we have to go by lab and clinical response. In ALF, more INR and HE, and in ACLF, bilirubin may be the driving one, I feel.
When there is no option for liver transplant, this can be tried, I thought. We can't be so restrictive. Liver transplant is very cumbersome, it's costly, it drain on the resources, but this is not difficult. I thought nephrologist have that role, and blood bank is coming to our rescue. We can try when the bilirubin more than 35, when the HE, we can try this.
I agree,
to some extent.
Yes.
Can I ask?
Experience in ACLF has been quite dismal.
Okay.
But your experience seems to be very gratifying, and this thing, is there any way we can probably improve that? And then, so what about the selection criteria in these patients? Most of them are quite sick when they come.
So one thing, this is not my thought, this is something that Dr. Eapen keeps saying. He says, what are your questions that you're going to ask when you select a patient for transplant? Why are you not applying that for plasma exchange? So I'm not saying that, plasma exchange is a much lower stakes game as compared to a transplant, especially an urgent transplant. But those should roughly be the same questions that we ask. Are we dealing with overt sepsis? Are we dealing with more than 2 organ failures? Are we dealing with respiratory failure in an intubated patient? We know that these patients, if they undergo transplant, are going to do badly. And it is sort of the truth that these patients will do bad with PLEX, irrespective of what we do. So that's generally the broad thing. We know that any treatment we give, be it transplant, be it PLEX, grade 1 ACLF will do well, much better than grade 3 ACLF. So the patient selection, so it's not that we want to show rosy results, but in patient selection, futility has to be thought about before we offer plasma exchange as well. We can still try it because it's a lower stakes game, but knowing that it may be a futile exercise. That's, that's probably vague, but that's my answer to that.
So ACLF grade 1 is the best option for PLEX. No. Grade 3 probably is not the...
no, not what I was trying to say. I was just trying to say that...
Just asking because grade 3 don't do well generally, and most of them are quite sick, and then we have hyperbilirubinemia. We have no other option except for doing PLEX.
So it would largely depend on the organ failure. If lung is the predominant organ failure, what we have seen is, lung and renal failure requiring hemodialysis, those patients do not do well, whatever we do. That's the truth of it.
Listening again and again from CMC, it's something new. What is your the results, or what is your thought on ACLF in Wilson disease?
Yeah, ma'am. So it's not been phenomenally great. I know that Wilson disease is one of those things which is actually plasma exchange has been used for a long time, but numbers are small. We have about, I think we have about, of the 600, about 20 or 25 odd patients who came with an acute Wilsonian crisis, and about 50% of them did well, but 50% of them did quite badly, and they deteriorate. Strangely, we see them deteriorate quite fast, but 50%, I may be wrong, but this is my sense.
Do you have any predictors, or is it the same Wilson index, something which you can say they will not improve, so that we can prepare the children or parents for the transplant?
Ma'am, honestly, I do not know the answer to that. I know that it's not been phenomenally great, but we have had patients rescued with PLEX, but that needs to be separately looked at. If I answer that, it will be wrong.
Thank you.
One more question. Just it's interesting to see in the team there is no surgeon or is involved. So I understand what you're thinking, but the problem is in ACLF, even if you do PLEX and patient improves, you're just buying time before transplant. So you make them, you optimize their conditions so that they become suitable and for transplant, for a graft to be available, whether it is a living donor or deceased donor. That's what we're trying to do in ACLF. In ALF, it's different. If you have time for the regeneration, they may get better.
So I actually apologize for that. Surgeon has to be a part of the team, and surgeon is a big part of the team. So that's a miss from my side.
Okay. So we usually start, whether it's ICLF or ALF, we do things simultaneously. In ALF, you list them for an urgent criteria, you induct PLEX, and then also you counsel the family for a possible living donation, so that whenever you can, if the patient improves with PLEX, then we don't push them for transplant. But if they don't, then we need to, because we may not get organ in status zone all the time, so need to be always prepared. It's always real time when you manage. When you talk, it's different, but when you manage, you always have the option.
I completely agree with that.
Starting everything together, so that if one succeeds, then you don't have to do that.
Definitely.
Very good.
I have 2 questions, sir. Sir,
Here. Oh, sorry.
Okay. So the first one is, when you are dealing with the ACLF, generally the patient presents with fever and the patient has an infection. If you are ruling out PLEX on day 1 because that infection is a contraindication, that becomes always a lingering point here. When the patient comes in, we start him on meropenem. Why not we start him on the PLEX on the 2nd day? Because even in your criteria, you told severe sepsis. And whether just a bacteremia is a contraindication. And why is it a contraindication? You told immunoglobulins. Those immunoglobulins anywhere are not working. That is the first question. The second question is, why steroids for 30 days. I understand for 10 days to suppress the inflammation. Why for 30 days in an ACLF patient? Are we not deteriorating the patient?
So the infection bit, very difficult to tease out infection in ACLF, especially when they present with fever and high counts. But I would think it's reasonable to give a couple of days. ACLF gives you that kind of time, especially when they're not in grade 3 and all, to do a proper sepsis screen, rule out SBP, rule out lung infection, rule out UTI, things like that, wait for your first set of cultures. And if those are negative and counts are still high, but it's a low lingering fever, there's actually no harm giving starting them on Plex, is my answer to the first question. Now, I would actually go back and say that it's active untreated sepsis that I would consider a contraindication, and not just the presence of a mere infection, which we can actually manage. Second is immunoglobulins is just one reason for thinking that we are actively removing that and we are replacing with FFP. Can that worsen the infection? Having said that, we have plexed people who have had infections as well, so long as we were sort of sure that we have it under control. Sorry, I forgot your second question. Viceroy. Yeah, again, something that I did not touch on is there's quite a bit of reticuloendothelial activation that is noted. So we know that it's a high ferritin syndrome. There is macrophage activation that is noted in these patients. So a higher dose of steroid obviously is going to be detrimental. We are talking about 10 mg of prednisolone with an antibiotic cover and close monitoring. So I'm not saying it should be for 30 days, but it is given for a little longer than the days of Plex, and patients have been sort of tolerating it well, is our experience. So it's not 40 mg of pred, but it's 10 mg, and they do generally tolerate it quite okay.
A couple of quick notes. Now, most of the centers would have not centrifugal, but rather membrane based. So, do you think the rest of the centers, one will be able to replicate the data? Other thing is, now most of the ACLF has been on like a specific etiology. Recently there's been one in JCH for dengue fever, like one Thailand group. So apart from Delhi, have you tried it in this? And there's also, there's one more addition. So there's been some talk on a preemptive Plex, as Dr. Vinish was saying, like, because most of the patients, especially on rodenticidal, you had a 69%. So only after 5 days is the LFT and PTN are going to increase. So why can it not be in this particular toxic, toxin mediated? Can it be a preemptive Plex?
Can I take the last question first? So with regards to preemptive Plex, the problem there is here the plasma exchange is not used as a way to remove the toxin. If that was the intended idea, we should be doing it as soon as possible from the time of ingestion. That's not the intended idea. In fact, we really don't even know if there's circulating toxin by the time toxicity is manifested. The idea here is so we are thinking that there is an overactive innate immune system which is driving the liver injury, which has actually been shown in a few basic science research that has been done from Vellore as well. And it's amelioration of this innate immune system overactivation that Plex and the low dose steroid is helping with. So we can do that only once the rodenticidal hepatotoxicity has set in. So preemptive, how preemptive? So are we talking about day 1, day 2? To the best of my knowledge, since we are not talking about removing the toxin, no role. But preemptive in the sense that are we plexing severe ALI? Yes, it makes sense. So again, many of these patients, the natural history is such that they do quite well. If the worst we see is a 10-time elevation of enzymes with an INR of 1.5 or 1.6 and they sort of get better, then they really don't need Plex, they really don't need transplant, they really don't need anything. It's just some monitoring that they need. But if you see that the 2 is becoming 4 and that 4 is becoming 6, then even before HE, that would be a preemptive Plex, would be my answer to that. Centrifugal versus membranous. Most big centers which are offering plasma exchange would have a blood bank. And blood bank apheresis machine is technically your centrifugal machine. So it should be okay to replicate, but so long as the team is happy with it. So I'm sure there are a lot of political issues involved in this as well as to who is offering the plasma exchange, who is directing it, who is deciding on it. So that every institution will have to come with an MOU and then work it out. But implementing it is really not that difficult because every blood bank facility will have an apheresis machine.
Thank you very much. That was very interesting. So the next speaker for the day would be Dr. Aswin Krishna, Assistant Professor from the Department of Hepatology, Madras Medical College. His topic will be HRS in ACLF versus HRS in decompensated cirrhosis. Are there any differences in diagnosis, management and outcome?
Good evening all. So my heartfelt gratitude for the committee members for giving me an opportunity to talk in this dais. So today the topic is AKI or HRS AKI in acute decompensation with ACLF. Any difference in the management, diagnostic protocol or treatment? So going with the basics, this is let's see how a normal liver progresses to cirrhosis. This is a CT of normal liver. Usually it progresses to steatosis, hepatitis, fibrosis and ends up with cirrhosis. Usually most common diseases we see is alcoholic hepatitis, NASH, viral hepatitis or autoimmune. So in steatosis, hepatitis and fibrosis stage there will be hepatomegaly. Later the liver shrunkens and forms cirrhosis. Liver shrunken cirrhosis and ascites forms. This is cirrhosis with decompensation. If a patient is having liver disease more than 6 months, either in form of steatosis, hepatitis or fibrosis, we call it as chronic liver disease. So what happens in acute decompensation with ACLF, we will see one by one. So here the liver is shrunken, cirrhosis, portal hypertension sets in. So there will be increased intrahepatic resistance. Once intrahepatic resistance increases, there will be splanchnic vasodilation. Splanchnic vasodilation is there, the cardiac output comes down. There will be less decreased effective arterial blood volume and cardiac output decreases, renal flow decreases, there will be renal ischemia leading to forming AKI. So in acute decompensation, it is mainly the pipe problem. There will be less flow. Because of the less flow, there is AKI. So our treatment aim will be to counteract the flow by giving vasoconstrictor, which counteracts, increases the causing vasoconstriction, increases the cardiac output, increases the renal blood flow, thereby the AKI improves. But what happens in ACLF? We have seen the prior CT. It is a chronic liver disease. Chronic liver disease may be hepatitis, fibrosis or even a cirrhosis without prior decompensation. What happens in this liver when there is an acute hepatic insult, which may be alcohol, viral hepatitis, Camdili. Patient may be, we have seen patient going to Walajabad or Triplicane and taking Camdili or any other hepatotoxic drugs or an autoimmune hepatitis. When an acute hepatic insult happens in this already injured liver, what happens? A nuclear reaction happens. A tsunami of inflammatory cytokines are released. A cytokine storm happens. It will not spare any organ, including the liver or the kidney. In the liver, it causes massive liver death, cell death. leading to an acute portal hypertension stage and leading to the vasodilation, and as mentioned, the prerenal AKA and HRS AKA sits in. Along with this HRS AKA, it also, this inflammatory cytostorm does not spare the kidneys also. It will burn out the tubulointerstitial cells in the kidney, forming acute tubular necrosis, ATN. And another, the increased bilirubin, the bilirubin in ACLF goes and accumulates in the collecting ducts, causing the capillary dysfunction due to mitochondrial dysfunction, leading to a specific entity called bile cast nephropathy or cholemic nephropathy. So in ACLF, in three spectrum of AKA is commonly seen. One is our HRS AKA, along with an HRS AKA, additional component of acute tubular necrosis and cholemic nephropathy. Let's see in our clinical practice how we can dissect it, identify this phenotype, and change our treatment according to that, so that the prognosis and the treatment improves. So KDIGO defines the AKA as increase in creatinine of more than or equal to 0.3 milligram per deciliter in 2 days, or increase in creatinine either 1.5 times from the baseline or 50% from the baseline in 7 days, or urine volume should be less than 0.5 ml per kg per hour for more than 6 hours. Once we identify the AKA, next the KDIGO asks to stage the AKA. Stage 1 is 1.5 to 1.9 from the increase in creatinine from the baseline. Stage 2 is 2 to 2.9. Stage 3 is any creatinine increase more than 3 times from the baseline, or creatinine more than 4, patient on renal replacement therapy, patient is in anuria. Then you classify by stage 3. Once you identify the stage and the AKA, day-to-day practice, I will be seeing which type of AKA we have. Less than 1% in cirrhosis and ACLF present with post-renal, we can identify by a simple ultrasound. And other than that, 35% of the patients present with an intrarenal AKA. In the intrarenal, and 66% present with a prerenal AKA. So how will we differentiate a renal from a prerenal AKA? The fractional excretion of sodium will be high, and urine sodium will be high in renal AKA. Meanwhile, one creatinine ratio, urine osmolality will be raised in prerenal. In day-to-day practice, we can use a common 2 test. You can see the cast. Granular cast will be predominantly elevated in the renal AKA. Hyaline cast will be elevated in the prerenal AKA. What I use is, we can simply use an urine PCR, which will be elevated in renal damage, and in prerenal it will be normal. So once you identify this intrarenal AKA, you can differentiate ATN from other by only liver biopsy, which we don't do in clinical practice. In prerenal AKA, if you get a prerenal AKA, you can divide again into a volume responsive or a volume non-responsive AKA, and volume non-responsive AKA is HRS AKA, again 35%, and volume responsive is 65%. So this was the old HRS AKA definition. Now the 2024 definition is that you should have a cirrhosis with ascites, and it should abide by the KDIGO guidelines for AKA. There should be absence of improvement after volume resuscitation in 24 hours. The old definition was 48 hours, and there should be absence of strong confounding factors like sepsis, drug-induced, and other acute glomerular diseases. So the ESL in 2024 established the spectrum of kidney disease in the cirrhosis. Initially we saw within 7 days they call it as AKI, less than 3 months they call as AKD, more than 90 days they call as CKD. So this is what the pathophysiology we already discussed. In cirrhosis, the AKI occurs mainly due to splanchnic arterial vasodilation, leading to the reduced blood flow, leading to a prerenal AKI or ischemia, renal ischemia, causing the spectrum of HRS AKI. Meanwhile, in ACLF what happens? The inflammatory cytostorm happens, the PAMs and DAMs release, they causes a various pathophysiology like SIRS, renal ischemia, mitochondrial dysfunction and microcirculation alteration. These all pathophysiology, not only the HRS AK happening, the various pathophysiology leads to 3-4 spectrum of kidney disease. It can be a HRS AKA or a concomitant acute tubular necrosis or a cholemic nephropathy, which either progresses or which recovers after the injury. This is the paper published in 2016, which compared the AK in ACLF and cirrhosis. When patient presents with AK in ACLF, they are found out to have high bilirubin, high enzymes, high acute phase reactants and multi-organ failure because of the inflammatory cytokine storm. This is a paper published in 2022. Again, they compared the AK in ACLF and acute decompensation. When the patient present in ACLF with AK, usually the patient present with a high incidence of AK grade 2 and 3. Meanwhile, in decompensation, it is in stage 1. The paper also suggested that the acute tubular necrosis is more common in ACLF than in HRS AK. So, once I know whether we are dealing with intrarenal or pre-renal AK, next my concentration will be to see any other confounding factors that is causing the AK. Like three confounding factors. First is liver-related factors. I will see whether patient is having any parasympathesis-induced circulatory dysfunction. Patient is having tense ascites, which is causing the intra-abdominal pressure, increased intra-abdominal pressure, any infection, shock, or variceal bleed. I also look for any kidney factors, like any structural kidney disease is there, any underlying CKD, prior history of CKD is there, or any other kidney factors are there. Also, we have to see patient is taking any other drugs, nephrotoxic drugs such as ACEs, ARBs, antibiotics, vancomycin, amphotericin B, and other contrast-induced nephropathy, any risk is there. Then why it is important to differentiate AK in ACLF and decompensation? Because the study shows that survival in ACLF with AK is much lower when compared to decompensation. So what are the other biomarkers? We have seen by doing a simple urine routine and urine test, we can differentiate intrarenal from pre-renal. What are the other biomarkers that helps to differentiate HRS from an intrarenal AKI? We can use cystatin C, NGAL, FABP, interleukin 18. These are all the biomarkers mainly produced in the tubulointerstitial cells, and they are raised during the inflammation. So when you compare this is a study published by Napoleon et al., which compared the AK in ACLF and acute decompensation. They found out the interesting fact that these biomarkers are elevated in ACLF when compared to acute decompensation, stating that in ACLF it is not only the HRS AK component but also the acute tubular damage occurring concomitant, and we should identify and treat appropriately. So this is the study published World Journal of Gastroenterology, which stated that the NGAL, FABP, other biomarkers are elevated in ACLF, which supports the previous statement that in ACLF, not only it is not the HRS AKI, but also the ATN or cholemic nephropathy is happening. Researchers, while studying closely the AK in ACLF and HRS AKI, found out an interesting fact that 3/4 of the patients, 75% of the patients are having bile cast in ACLF when compared to decompensated cirrhosis, which lead to further studies, and they found out that high bilirubin in the ACLF accumulates in the collecting duct, affects the mitochondria, causing the mitochondrial dysfunction, leading to the formation of cholemic nephrosis or bile cast nephropathy. Which patient you will suspect bile cast nephropathy, especially when the bilirubin is more than 15, when the patients present with SIRS, hypokalemia, or patient present with hypouricemia. this cholemic, what happens if you neglect this cholemic nephropathy, or if you concentrate on dialysis or vasoconstrictors and you neglect this cholemic nephropathy, this will progress to ATN and lead to CKD, finally leading to worse outcomes. So in your clinical practice, then which patient you will suspect cholemic nephropathy? This study by Raki Maiwal et al. In 2022 found out that if your patient in ACLF is having bilirubin more than 30 with AKI, patient is more suspected to have cholemic nephropathy than acute tubular necrosis. Not that the patient may have only cholemic nephropathy, there will be also acute tubular necrosis, but chance is that patient may have AKI most probably because of this cholemic nephropathy. These are the further studies. Further studies led to finding that repair markers such as osteopondin, EGF, injury markers such as NGAL and lipocanin was elevated in acute tubular necrosis when compared to HRS-AK. These all biomarkers are still in pipeline, not used in the clinical practice. So they took almost 125 patients for post-mortem analysis. They took a kidney biopsy in cirrhosis patient, found out that patient with cholemic nephropathy had a high staining of aquaporin 2 and SIRT1, when acute tubular necrosis patients had high staining of SGLT2 and HIF1 factors. So in the daily clinical practice, when you will suspect cholemic nephropathy or acute tubular necrosis, what are the simple methods? Do a serum bile acids and NGAL. If NGAL is high, then you can suspect acute tubular necrosis, where our treatment will be towards a renal replacement therapy. While high serum acid, bile cast in the urine, I will focus more on cholemic nephropathy, where the studies are in pipeline showing that UDCA may decrease this bilirubin and abrogate the cholemic nephropathy, and also cholemic nephropathy can be further treated by giving extracorporeal membrane support, exchange like plasma exchange. So we have talked about the diagnosis part. Coming to the daily clinical practice, how to treat a patient with AK in ACLF or cirrhosis. When a patient comes to in the OPD or ER with AK with ACLF, you have to stage the AK, which stage it is, define AK, then after careful history and clinical examination, assess the volume status and identify the AK is come with shock or without shock. If you are using albumin at the day 1 in patient with ACLF, you should be very careful, because in ACLF patient will have high bilirubin, and this albumin will be converted to nitrogenous albumin, which is again a toxic compound, and this nitrogenous albumin causes severe coagulation disorder in addition to the coagulation disorder already in the ACLF. So when the patient present with shock, you have to give volume. Only when the patient present with shock, you have to volume expand with 5% albumin, then assess IVC. If it is more than 40% collapsible, you get a 40% collapsible, 5% albumin along with the crystalloids should be tried. If the IVC distendability is less than 40%, then you switch over to 20% albumin. If your patient is presenting without shock, then you should be very, very careful. They first differentiate whether it is structural or functional kidney disease. If it is functional kidney disease, then you have to see the IVC. If it is less than 40% collapsible, don't go for albumin. It can lead to volume overload, severe pulmonary edema and worsening of ACLF. If there is non-distendability of IVC, then go for early initiation of terlipressin and manage HRS-AK. If there is more than 40% collapsibility, then you treat with 20% albumin and daily assess and individualize albumin case-to-case basis. What vasoconstrictors we commonly use? We use terlipressin, noradrenaline, midodrine and octreotide. Noradrenaline in a dose of 2 mg up to 12 mg per day we use. Norad at a dose of 0.5 to 3 milligram per hour we use. Midodrine 7.5 to 15 milligram 8 hourly along with the octreotide. Then I will consider discontinuing vasoconstrictors when there is no improvement at all after 48 hours. After 2 days there is no improvement. When the creatinine totally improves less than 0.3 milligram per deciliter from the baseline, or I am planning for renal replacement therapy, or I am planning transplant, or total duration of 14 days I have done, I have not achieved my target, then I will consider discontinuation of vasoconstrictors. Why this much fast step is needed? Why we have to go in a fast moving manner than a traditional manner, giving albumin terlipressin, first giving volume resuscitation for 2 days as per the old protocol? Why we should give that terlipressin at day 1? Rakim Ayuval studied in 35 patients, they gave early terlipressin, and another 35 patients with late terlipressin after slow volume resuscitation after 2 days, found out that when you give early terlipressin in ACLF patient, it has found to help in better reversible of HRS AKI and also improving the short-term mortality. So how to improve the outcomes? You use the cardio criteria, target MAP, and use biomarkers whenever feasible. So why it is important to identify? We have seen the physicians usually going in a routine setup, initial volume resuscitation not improving, start vasoconstrictors not improving, then go for dialysis. Why the earlier identification of acute tubular necrosis or a cholemic nephropathy is essential? Because early initiation of dialysis has shown that not much significant in 28-day mortality, but it has shown a significant improvement of intradialytic hypotension, less hypotension during dialysis, better ultrafiltration goals, better urea reduction, and better response to dialysis. So which patient in your clinical practice you think, you feel, or you will suspect that in these patients are more prone for dialysis or they will be beneficial by dialysis? Paper by Mayall again at 2022 paper, Liver International found out that patient with bilirubin more than 25, MELD more than 35, or ARP more than 11, these patients are less prone to improve by vasoconstrictors, and these patients will need a dialysis. Is dialysis the trump card or the life-changing? Never. Journal of Nephrology in 2022, sorry, it's not 2020, 2022 published that when they did dialysis in cirrhosis patient, they found out that there was not much significant improvement mortality. When patient compared without, the mortality was almost same. But you should be more careful in selecting the patients, which patients you are going to dialysis. You should take patients when potassium is more than 6, pH, metabolic acidosis, volume overload, hyperkalemia, respiratory failure, or persistent AKI. So in a nutshell, you after history and physical examination, remove the offenders, stage the AKI, and decide whether you are going to be dealing with a structural kidney disease or functional kidney disease. You do a simple urine routine and fractional excretion of sodium, determine whether you are dealing with HRS AKI, cholemic nephropathy, or acute tubular necrosis. If it is a non-HRS AKI, directly go for renal replacement therapy. If you are dealing with a HRS AKI, then you give volume response. If not volume response, you deal with liver transplantation or combined kidney liver transplantation, which Sir will be talking in soon. And last case discussion, over sir, 2 slides. Patient presenting with hepatitis B, initially bilirubin of 7.5, after starting antivirals 4.1, some 1 or 2 papers telling about dual antivirals, even after starting 7.1, then patient coming with bilirubin of 27. Here the 27 with ACLF, with AKI, INR elevated, and hepatic encephalopathy. In this patient, the intensivist team wants to start an early HD, but we saw the basic urine routine, which was showing granular cast along with bile salts. We asked for bile salt. Luckily, we went for urine NGAL, which was 180. which made us to think that patient we are dealing with HRS, aka maybe a cholic nephropathy. We were able to do a plasma exchange with a bilirubin filter, and lately the bilirubin, after 3 cycles of plex, the bilirubin has reduced from 27 to 14, which 14, later 10, and at the June this was the LFT, and patient completely improved. So this was the CT of that patient where there was cirrhosis with mild collaterals. So my last line, the major difference between AK in ACLF and decompensation, the prevalence is almost same. We have seen in decompensated cirrhosis, it is mostly functional. It is the blood flow part, where in ACLF it is the more structural part. Since it is a blood flow part, you correct the blood flow by giving terlipressin. Decompensated cirrhosis AK more improves. Since we are dealing with a more structural part, dialysis may be needed in ACLF patient, and prognosis is worse in this paper in by Apasal. I think a contribution from German paper says that prognosis is worse in AK in ACLF patient when compared to prognosis in decompensated cirrhosis. And personally, I feel, though they tell that worse prognosis, I feel I should have a patient with AK in ACLF rather than a decompensated cirrhosis, because once you treat this AK in decompensated cirrhosis, we have seen the first slide, the liver is already gone, cirrhosis is shrunken, and ascites is already there. You can only prolong the disease. You can only prolong and give a time for 3 months for liver transplantation. Meanwhile, in ACLF, if you are able to get the right patient, if you are able to correct 4 factors, the etiology, the inflammatory part by giving a correct time GCSF or a plasma exchange, and if you correct the AK and the triggering factor, maybe an infection, most probably the acute hepatic insult, if you are able to correct these 4 factors, like the last patient, you will be able to have a normal life. Thank you.
Thank you, Dr. Ashwin. For want of time, can we skip the questions and keep it for the last after finishing the last lecture? Please sit down.
Thanks for the organizers for giving me the opportunity. I am a consultant nephrologist in Apollo Hospital. So today, just we're dealing with only 3 case scenarios that I was a part of a transplant team. We have an effective transplant surgeons and with a separate ICU, and we have done almost so far 15 liver and kidney transplantation in our center, and I was part of almost 10 transplants. So this is today I'm sitting in front of a group of lions. So please forgive me. This is it's a dinner time, and don't make me a prey, and the organizers has to pardon me if I do any mistakes in your area, and please rectify me also. And this is the case number 1. He's a doctor from Tripura. So he's a long-standing diabetic with hypertension. He's having a CKD and DCLD also. So he had a creatinine of around 2 to 2.5 for the last 2-3 years, and his CLD was decompensated this year, and so we have decided to go for we already registered him in a deceased donor, and the renal transplantation and combined liver and kidney transplantation was done in February for him, and he's doing very stable. I had a stormy post-transplant course. He had many infections, like he got CMV, adenovirus and everything, and he recovered. And yesterday he called me and he said his creatinine was 1.3 and he's having stable liver function and is doing very well, and he is an ophthalmologist and he started doing his practice actually. He's from Tripura. So what made us to go for a liver and kidney transplantation in this patient? His GFR was 30 ml only. So he was not in a stage of requiring dialysis at the time of liver and kidney transplantation. His GFR is only 30 and his creatinine was 2.49 the day before liver and kidney transplantation. So we just adapting the OPT and guidelines. OPT is an organ procurement transplant network from US.
and this is a messy slide, and they given guidelines for each category for chronic kidney disease with chronic liver disease, and AKI with chronic liver disease, and with metabolic disease like atypical hemolytic uremic syndrome and primary hyperoxaluria. So in those patients, they have a normal liver function. In those situations also, we adapt to choose a combined liver and kidney transplantation. And with nutshell, I just taken a simple words. So patient is having a CLD with CKD. CKD means the GFR is less than 60 ml per minute for 3 months duration. This is the standard definition. A patient should be on dialysis either, or his GFR should be less than 30 ml per minute for at least 12 weeks. So we should consider him for a combined liver and kidney rather than going alone for liver transplantation in DCLD. In AKI, either the patient is having HRS or some other reasons for an AKI in CLD, with requirement of dialysis at least even once in the last 6 weeks period, with GFR of less than 25 ml per minute. This group requires both combined liver and kidney transplantation. And I told in metabolic disease, though the liver function is normal, because liver is the main culprit for the genetic and metabolic abnormality, though these patients present with CKD stage 5 or end-stage renal disease, where the renal transplantation is very, very mandatory. The liver also we do transplant along with the kidney because of their primary culprit in the normal functioning liver because of abnormal genetic and abnormal metabolic factors. So this duration guidelines differs from the United States and from the Europe and Canada. So even initially that United UNOS from US also given a guideline like the patient with CKD or an AKI of more than 12 weeks initially they told, and they revised to 8 weeks, and now they revised even to 6 weeks of GFR less than 25 ml. They take into a consideration to do a kidney transplantation along with the liver, though the patient doesn't require any dialysis. So these guidelines is being changed by the UNOS, but whereas Europe and Canada they follow different timelines, they still adapt 8 weeks and 12 weeks of low GFR as the criteria to go for a combined liver kidney, whereas like in India and in most of centers in India like RELA and ILBS, they adapt UNOS protocol only. So we do combined liver kidney transplantation if the GFR is less than 25 ml per minute for at least 6 weeks duration. Why this particular patient with a doctor having a creatinine of 2.4, what is the purpose of doing a kidney transplantation? He is not on dialysis. Means there are a lot of evidence for that to go for a combined liver kidney transplantation, because this gentleman had many episodes of hepatorenal syndrome before transplantation, and he means every time his creatinine was waxing and waning type, is going high and coming down after albumin and terlipressin. And intraoperatively, this gentleman, after doing liver transplantation alone, he may have altered hemodynamics, his blood pressure may drop, he was in DAC, he was in coagulopathic. So this also affects the new graft actually, if the already existing the old kidney can be affected because of this, and this kidney function may worsen very fast. And the usage of the important thing is calcineurin inhibitor, that is we use as a post-transplant immunosuppression is commonly, that can worsen the already existing CKD very fast. So there are a lot of numerous preoperative reasons and intraoperative because of altered hemodynamics and DAC and high bilirubin load can affect the already existing compensated kind of kidney disease that can easily decompensate after liver transplantation alone. So it's better to do a combined liver kidney transplantation, and we can easily and safely we can use all the tacrolimus and CNI inhibitors safely after transplant. So why can't we wait? Just do a liver transplantation alone, let the kidney fails eventually, and then do for a renal transplantation in the subsequent period. So that is also not a correct option, because the data from your hepatic journal shows the chance of immediate post-transplant acute worsening of renal failure in patient of CKD is nearly 96% of patients. Almost like all patients, they worsen very fast and they require a renal replacement therapy like in the form of CRRT or dialysis in the immediate post-transplant period. And once they come out of that immediate stormy course, and they may reach end-stage renal disease in another 5 to 10 years very fast. So it is always safer to do a combined liver and kidney transplantation, and this is the survival benefit curve taken from the American Association of Study of Liver Disease. Here you can classically see if a liver transplant alone, their survival is very good. That is obviously liver transplant alone. If you do a combined liver and kidney, if there is a good survival benefit in sequential liver and kidney transplantation compared to a kidney after liver transplantation. So you can see the survival benefit is not there if you do a kidney transplantation after liver transplantation. If you give some time gap, definitely this patient don't do well. The reason for this is because the patient is need to go undergo 2 surgeries, 2 different donors. It's not from the same donor. We have to choose a 2 different donor and 2 different immunological profile, and 2 different time you need to give immunosuppressions. It's not one time I'm going to give a hit him hard and reduce the chances of rejection. It's not like that. So it's taking up 2 different surgery and doing a surgery on a immunocompromised patients. Already you have done a liver transplantation for that patient and he's on immunocompromised drugs. So you subjecting him to another surgery after quite some period of time, and allowing him to chance of more immunosuppression agents to be used because it has come from the different donor, and the chance of infections also will be very high. So clearly this survival estimate curve also shows combined liver kidney transplantation give a better survival than to do a kidney transplantation when the things go wrong and the kidney fails after liver transplantation. So there are risks and benefits of doing a simultaneous liver and kidney transplantation. Risk is a procedure related complications. So it is a big surgery. It is renal transplantation is very straightforward, simple surgery, can be done in 2-3 hours. It is just connecting a renal artery and renal vein and ureter. It's very simple surgery. Whereas your hepatic transplant is very complex one. So in this, along with hepatic transplantation, we need to do a liver kidney transplantation also. So it needs more surgical expertise in this thing, and it has more operative complications are more compared to either liver or a kidney transplantation. And this patient I already mentioned, if you're doing a combined liver and kidney, there is enhanced chance of altered hemodynamics, BP may drop, and patient may have a worsening acidosis. We require an intraoperative CRRT. Always it is our protocol, we'll keep the machine ready, CRRT machine ready inside the theater itself. Whenever things go wrong, they immediately connect, or along with the CRRT, the patient we do a liver and kidney transplantation. This is our usual protocol. So it leads to more risk and more complications to that recipient. And benefits, always liver, there is called a liver effect. Liver effect means liver is a mopping effect. So it absorbs whatever the donor specific antibodies or T cell allo recognition, whatever it can absorb the T cells and B cells, and it gives an immunological benefit to the recipients. So in these patients, you should not require more immunosuppression, no need for more induction agent like ATG or basiliximab. So you can give only a little bit immunosuppression for these patients. That is one of the important benefit in transplant aspects. It's if you see a kidney transplantation, you need to give a immunosuppression for a long period of time, and you need to give a very high immunosuppressions. Whereas in liver or either cardiac or lung transplantation, they don't give a much immunosuppression like a kidney transplantation. If you do a liver and kidney transplantation together in a single recipient, liver has a mopping effect. It mops off all the antibodies, B cells and T cells, and it is having immunological benefit to the recipient, and we can give only a minimal immunosuppression to the patient and less chance of infection for that patient. And I already mentioned it is a single surgery, single donor. So you can finish off all your work in a same setup and finish it off all the don't allow the patient to do 2 different surgeries, 2 different donor, 2 different immunological profile, and 2 different immunosuppression needs to be high at the time of transplantation, because the rejections are very common at the early period. So that can be avoided. These are the benefits in doing a simultaneous liver kidney transplantation, and I already mentioned it has an excellent survival benefit compared to a sequential first liver followed by a kidney transplantation. And another an approach is there. It is called Indiana approach by Exer et al. So what they do, it's by whenever you get a liver and kidney transplantation, it has to come from the deceased donor only. What they do a liver transplantation first, and they put the kidney in the hypothermic perfusion machine. So basically, the machine perfuse for the 2 to 3 days. This machine was initially not available a couple of years before in India, but it is nowadays it is in India also. We have used for 2 patients actually. So this machine has it's a costly machine, but in Apollo we got this one for a demo purpose, and we have done for 2 patients. We put in the kidney in the perfusion thing, so it does the cold perfusion thing and all. It is being done by that machine, so that the liver transplantation process is getting finished. But we didn't try this approach. But what this approach says, you do first finish off the liver transplant and put the kidney in that machine for 2 to 3 days. Because the initial 2-3 days is a very crucial time where you can expect DAC, high bilirubin load may be there. It takes at least 2-3 days time for decremental in the bilirubin load. By the time your DAC, the BP is stable without recurring of any inotropes, and bilirubin load is getting cleared, that is an ideal time put the new kidney, because the new kidney is not tolerable to this insults of high bilirubin or DAC or coagulopathy. So once everything settles in 2-3 days, you can get the kidney from that machine and you can do a transplantation. And what they say, ideally doing by this, there is a big disadvantage is machine, the kidney is outside your body. Sit in the machine for more than 48 hours. More than 48 hours, definitely it leads to a delayed graft function, because just putting a machine outside your body increases the chance of delayed graft function. But what they found in by the Exer group, this Indiana approach, you can see clearly they say survival benefit is very high over 4 years period when they do a delayed kidney transplantation. Means delayed means you can delay up to 48 hours or 72 hours. Not delaying for a period of 4 to 6 weeks or 8 weeks. So this is called Indiana approach, and that we didn't try actually, but it's been given in the literature. And even many centers following, because this is a recent approach, many centers in France and Europe, they are adapting this thing, and it's recently published in 2024 from the France single center. They said this approach is good, beneficial for the combined liver and kidney transplantation. And I already told having an immunological benefit, no need of any induction, no need of any eye immunosuppressions. You can safely stop the steroid after 1 year when you do a combined liver kidney transplantation. And this is a very simple thing, what method of GFR that you adapt in measuring the renal function when the patient is having cirrhosis. It is definitely not creatinine based, because creatinine is definitely not giving a correct value, because most of the patients in CLD is malnourished. They are having a low muscle mass. They may have a false low creatinine value, and moreover creatinine is measured by the Jaffe's method. Basically Jaffe's method is a chromogen based, color based method. So most of these cirrhosis patients will be very thick. Then yellow color can give you false low value in the creatinine. So creatinine based estimation for the GFR in CLD patient is not an appropriate one. For that, there are a lot of biomarkers is there, and this is a newer formula, the Royal Free Hospital GFR. So it incorporates 7 different variables where this GFR includes ascites, urea, sodium, INR into consideration and calculates the GFR. This is being followed in many of the NHS centers in United Kingdom, and many centers in Europe, and even in India. ILBS is doing a study to validate this GFR in our Indian patients, whether it is appropriate to use in Asian populations or not. But this GFR calculation is not validated in African and Afro-American origin. but there are a lot of studies is going in India to validate for whether it's appropriate for Indian patients or not. But the most common widely used GFR calculation in our practice is CKD EPI and MDRD formula. And coming to the case number 2, and this is a 12 years old boy from Tanjavur. He was getting dialysis there because of his condition is called primary hyperoxaluria. So he's having excessive calcium oxalate deposition in the kidney, in the bone, in the cardiac muscles, and he referred to us for a renal transplantation. His serum oxalate level was 125. So this transplant was done in 2016. That time, it was there are only anecdotal reports of doing combined liver and kidney transplantation for primary hyperoxaluria. So there are only few centers in India that are doing. Actually, luckily I was part of doing a transplant in this particular small boy. So that time we have decided to go for a sequential liver and kidney, liver followed by kidney transplantation. So we did liver transplantation first. The idea of this one is we have to bring down the oxalate load. A normal oxalate level in a normal individual is less than 20. The supersaturation of oxalate level is 30 to 40. So if it's anything oxalate level more than 40, it goes and deposits in the kidney, cardiac muscles, bone marrow and everything. So it leads to a cardiomyopathy, CKD stage 5 and requiring dialysis and severe LV dysfunction like that. So in that period in 2016, so to reduce the oxalate load, because liver is involved in the metabolic pathway of this primary hyperoxaluria. Primary hyperoxaluria type 1 is because of alanine glyoxylate transferase deficiency, so that glycolate is not converted into an oxalate. For that AGT enzyme is very, very essential. If it is deficiency, excessive oxalate accumulates in the body and it deposits in the kidney and leads to a end-stage renal disease. So this was the approach that we followed in 2015. We have done for an iFlex dialysis for him, and then the oxalate level has come down from, I'll finish, 125 to 75. After that, we have done a liver transplantation. So once we did the liver transplantation, his oxalate level came down from 72, it is up to 29, 26. After few weeks, exactly after 6 weeks of liver transplantation, we have done a renal transplantation. So his oxalate level reached normal thing, and he is doing well now. And he is recently joined college, and his recent creatinine, he met me 2 months before with 1.1 with having normal liver function. For him, we have stopped steroid because he's having both liver and kidney transplantation. We have stopped him steroid and we put him on only a low dose tacrolimus 1 mg twice daily and MMF 180 mg twice daily. That's all. So this I told. What's the purpose of doing a liver transplantation? And this is the newer drug. This was the approach what we followed in 2016. This is totally changed now. So with the availability of newer molecule called lumasiran. So basically lumasiran blocks this glycolate oxidate, so it doesn't allow the glycolate to convert into glyoxylate. So it blocks the pre-entry pathway itself. So with the availability of lumasiran, nobody in the western part of the world are doing combined liver and kidney transplantation. We do only a kidney transplantation, and they give this lumasiran every 3 months. But that is not possible in setup like in developing like in India. You just imagine the cost of lumasiran. One vial cost 1 lakh US dollars. It comes to around 80 lakhs. So that has to be used once in 3 months. So almost the patient has to spend 3 crores per year. For that, patient can do a liver and kidney transplantation in Indian setup. But this is easily covered by insurance in European and US countries. But their standard of practice is completely changed. They never do liver transplantation. They do kidney alone transplantation, and they give lumasiran, this agent, because it is covered by insurance. And this is the last case that this patient we have recently underwent transplantation in the month of August 2024. This lady is referred from Erode. She was doing dialysis there in the Erode. So she was having atypical hemolytic uremic syndrome. It's only a kidney only is involved, liver is okay, but because of the genetic abnormality, she is having a CFHR1. This is complement related factor 1 mutation. So for that, its liver is a main genetic thing, like to take care of these complements. Liver, where is the complements is being produced. So that is defected in that particular lady. This was the genetic analysis for that lady, CFHR1 mutation. For that, we did a liver and a kidney transplantation, because if you do renal transplantation alone in these patients that atypical HUS recurs within a matter of minutes to hours. On the table itself, it recurs because there's a problem is somewhere in the liver, so it has affected the kidney. If you don't do anything for the liver and you do only a kidney transplantation, almost 90 to 95% of the patient, they lose the graft within hours of transplantation. So liver has to be transplanted along with the kidney. So for this particular lady, we have given Similac, and we have monitored the complement levels, and we have given prophylactically FFP because the plasma is rich in complements, so that we have given prophylactically along with the surgery and operatively and post-operatively for 3-4 days. After that, this complements level we were checking, and the patient reached a stable complement, and we plan to give an eculizumab. Eculizumab is a newer drug for the atypical hemolytic uremic syndrome. We bought from France, and we kept it ready, and we never used for this patient. Unfortunately, this patient didn't require the eculizumab, and she did very well after liver and kidney transplantation. And day before yesterday, she went back to E-Road, and after 1 month of transplantation, from there she messaged me. Her creatinine was 1, and she's having a normal liver function. These are the eligibility guidelines that we follow for the atypical HS. They're just skipping for the time sake. And this is a newer drug I told, eculizumab. This is also in Western thing, they don't do a liver transplantation in atypical HUS. They do only a kidney transplantation, and they give an eculizumab, this drug. This drug also should be given once in 2 weeks like that. But just see the cost of this drug. It is costlier than that Lumasiran, other drug. The patient has to spend 5.8 crores per year. But always Western, they see they said they don't want an additional surgery for their patients. They can easily manage with the drugs. And coming to the last slide, and we have done combined liver kidney transplantation in our center for other rare diseases like methylmalonic acidemia, some inborn error of metabolism in a pediatric patients. They are doing very well actually. And we have done almost 4 primary hyperoxaluria patients with liver and kidney transplantations. All are doing well. And 1 patient with an ARPKD, autosomal recessive polycystic disease, that child had a congenital hepatic fibrosis with renal failure. The child was on peritoneal dialysis. We did a liver transplantation initially because we want to give some time, because it's a too small, tiny child. We didn't want to do both surgery at the same point of time because it needs more technical expert. It's more complicated thing. So we did liver transplantation first for the child, and after 4 months of period, the child was on PD only during this period. After that, after the 4 months, we did a kidney transplantation, and the child is also grown up well. Now, almost 3 months post liver and kidney transplantation, the child was doing well. Thank you.
Thank you very much, Dr. Saravanan. That is a very informative lecture. For want of time, we can just have one brief question and a brief question.
Can I ask, I think both speakers are there, how do you use these cystatin C and
it's only thing is the cost factor, sir. But otherwise, it's it is what they say, it is the best thing. It is well validated in cirrhosis patients, even not only in cirrhosis, even for our CKD patient. What they say is the best marker compared to a creatinine. But only thing, cost factor. So cystatin C may cost in our setup in Apollo, it is 5,500 rupees. Whereas in outside like lal pads and SRL they're doing for 2,500 rupees. But compared to a creatinine which is only like 50 to 100 rupees. So why to spend a more amount of money for a costly test? But it's highly well validated in both in CKD and CLD.
So all these criteria use GFR, no, for combined.
So what we commonly use in the MDID formula only, sir.
Okay. Because so do you use any nuclear medicine studies for estimation of GFR, DTPA scan and other things?
DTPA scan is validated in renal patients, but how far well validated in cirrhosis patient is not well studied, because that technetium, because it has to be, I think, metabolized in the liver, no sir?
No, we generally use TTPA scan as a pre-transplant evaluation, whether the patient needs kidney also. So usually the GFR is calculated by DTPA, and we also use this 24 hours urine protein ratio. Do you use urine protein creatinine ratio?
Yes, that and all we will check.
Generally use it's a pre-transplant setup.
Yes. But commonly what we use is like simple thing is MDID formula.
And this Indiana is mainly for DDLT setting. It's not for LDLT setting. Both France and US are predominantly deceased donor programs. So it's very difficult to gauge how the liver is going to work. But if in the living donor setting, liver generally works well. And if you don't do kidneys, if they are unstable, you do postpone it for the next 48 hours or so in living donor setting. Otherwise, generally it's done simultaneously these days.
Live donor is difficult to get it, like liver and kidney. It's two different donors we have to find.
Yeah.
But we have done for 2 kids actually. One is grandmother and one is father donated. Other is one grandfather and mother donated. Like that we donated. But like no, it's difficult to get 2 live donors.
Morbidity is more.
In the same person we don't take actually. It is not moral to take same liver and it is not morally correct also.
Are there any more questions? If there are no more questions, I'll close the session. Thank you.
Thank you.
Thank you, chairpersons. I would like to invite Dr. Ganesh to felicitate Dr. Saravanan, the shawl. Thank you, sir. Thank you for coming and giving a lecture. And I'm here to thank everyone who are assembled here. We had a very good academic evening. I would like to thank the Pattern President and Secretary for organizing this meeting, and all the audience, participants, presenters and chairpersons for making this event very successful. And I would like to thank Residency Tower for the ambience, and our pharmacological sponsors, Daris, and we all agree that it's a very wonderful evening. We had a lot of good interactions, and we'll catch up for the next midterm meeting, and then EACME will catch up for the same. And it's time for cocktail dinner. Please join us for the cocktail dinner. Thank you very much.